Very good. Am I muted or are we live there?
You are unmuted.
Okay. All right, good morning. Jay, go ahead and advance for me if you would.
It's not advancing. Just a moment here.
Yeah, you're on my screen. There you go. Okay.
There we go. Now we're in bed.
All right. So you guys had chapter 7 as homework. Did anybody have any questions on chapter 7? Anything that the answer you put, you think your answer is the right answer? No? Did anyone catch the game show yesterday morning? Anybody do that? Okay. All right. If you didn't do that, it probably would be a good idea to go back and review that, because I put a couple of questions in there where the format of the question was written in a specific way. It's really easy when we're taking a test to read an answer, think it's right, and choose that, and then move on. Where a better answer is further on in the answer options, and you missed it because you quit reading. I had 2 or 3 questions like that on the test yesterday. So it was designed to bring your attention to the fact that during the test, read all answer choices before you make your decision. Okay? Let me go ahead and get scores for chapter 7. Sheila, 100. Jaden, that's okay. Ariana, 95. Ariana, do you have 1 through 6 for me by any chance? Somehow I've missed those.
I have 5 for 100 for 5.
Okay.
100 for 4. You said 5 through
1 through
1
6.
through 6. I have 95 for 3, 100 for 2, 100 for 1, and then what was the other one?
6.
95 for 6.
Thank you. Audrey? Ethan?
90.
Thank you. Ashley? Fine. Emily? Okay. Mercedes? Martina? Thank you. Susie? Amanda? Okay. No problem. And I also need 1 through 6 from you as well. Brittany? Madison? Rain? Olivia? Olivia, do you have 1 through? Okay.
1, I got 100, 2, 90, 3, 100, 4, 100.
Very good. Do you have any questions on any of those from the previous chapters? All right. Anybody have any questions you want to ask before we get started? Nope. Everybody good? All right. Okay, go ahead and take us forward, Jake. This is our last review. This is it. So I'm going to go through these very, very quickly. You should have these down by now. But if for some reason you need a review, the beginning of this class is what you're going to want to look at, okay? Beginning of class 6. So we perform the skill as directed on the care plan. We follow the care plan, the whole care plan, and nothing but the care plan. While we're doing that, we're going to observe for any abnormalities, which would be changes or anything different, and then we would report those to the nurse. Every skill starts with the opening. Every opening starts with a knock. You're going to greet the resident by name. You want to introduce yourself by name and title and explain what you're there to do. You're going to get consent. Once you do all of that, then you can close the curtain, wash your hands, and get your supplies. But our super important step, do not touch the resident until your hands are clean. Very good. When we're getting supplies, we always think about gloves. This should be top of mind. You cannot wear gloves for everything. It puts your patient at risk. But you do need to wear gloves if you're going to be exposed to body fluids, personal skin, or non-intact skin. If you decide to wear gloves, the first thing those gloves should touch is the patient. Once you've touched the patient, your gloves are considered contaminated. So you want to pay attention to what you're touching in the area with those contaminated gloves, just to try to minimize the spread of infection. And then we have to remove our gloves correctly. To do that, we pinch up at the cuff, pull that one off, and then go underneath to pull the second one off. The rest of our supplies, when we get them, we have to have a clean place to put them, and that's what the barrier is all about. A barrier provides a clean place to put our clean supplies. We go get that barrier first, and we put it on the table. Then we go get our supplies and put those on the table. Don't hold the supplies against your uniform. By doing it this way, barrier first, then supplies, it keeps you from accidentally contaminating those supplies. One of the supplies you may need is a privacy blanket. Please remember, your care plan will not tell you you need gloves. It will not tell you you need a privacy blanket. Your care plan does not tell you you need a barrier, does not tell you any of the principles. You have to know these. So if you are doing a skill where your patient is going to be uncovered or undressed, we're going to cover them up with a privacy blanket. So basically, if we're taking the sheet away or their gown away, we're going to cover them with a second layer, so something over them. Now, you can use anything as a privacy blanket. You can use a towel. You can use, anything you have laying around. But for the test, we're going to use a very specific privacy blanket. Okay. This is to help keep the patient private, but also to keep them warm. Because remember, your idea of a comfortable temperature and theirs might be a little bit different. You're going to put the blanket on over the sheet. Don't snap it or shake it. Just lay it on over the sheet and pull that sheet down underneath. When we go to remove the blanket at the end of the skill, when you remove it, you want to do it after you take your gloves off. Okay, good. Any questions so far? All right, linen rules. Most of these are repeats. We've already gone over most of these. Good morning. So linen rules, your linens can't touch your uniform. You have to have clean hands to get your linens, and we don't want to snap or shake those linens. We know all those. Those are our principles that are repeated in other areas. Clean rolls toward me, dirty rolls away. And we use this when we're going to put anything under a patient on the bed, whether it's a sheet. Today, we're going to be doing Peri-Care, so you'll see this principle again with the chucks. Anything that goes under the patient, this is how we remember it. Clean rolls toward me, dirty rolls away. Don't let anything touch the floor. We don't put dirty items on the floor. We don't let clean things touch the floor. Nothing on the floor but feet. And then anything that we get and don't use, we're going to discard. Put it in dirty linen. Don't leave it in the room for later. Scoot and roll. Patients should be in the middle of the bed at all times. So your patient will do this naturally. If you tell somebody to turn on their side, they'll actually shift so that their bottom is in the middle of the bed. That's just something that we all do unconsciously. But if we have to move the patient, we have to remember they have to be in the middle of the bed. So we'll scoot them toward us first and then roll them facing away from us. Don't turn somebody toward you, always facing away from you. And the best way to remember that is remain behind the patient's behind. Okay. Washing rules. We do a lot of washing, guys. We wash hands and feet. We wash bodies and peri area. We do a lot of washing. There's a lot of washing skills. You only need one basin as long as you don't add soap to the water. That water stays clean for rinsing. So basins are no soap zones. Good. When you go get water, you're going to use a paper towel to turn that faucet on. It should feel warm, not hot, not cold, just warm. And we're also going to ask our patient to check it. Change that water if it gets cold or soapy, like if you're taking a long time to do the skill. And whatever we wash, we rinse. Whatever we rinse, we dry. If you're going to wash a wet body opening, which would be eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions, we're going to use that leaves method that we focused on at the end of last class. We're going to see that again today. So if you didn't get it last class, it's okay. We're going to go over it again today. Make sure you're not getting your surface wet. We want a barrier on the table to protect the table surface. If we're doing foot care, the barrier will be on the floor, basically underneath the basin, wherever your basin is. And when we're working with a patient in bed, we also want to protect the sheets. If we're going to use lotion, we warm it up in our hands first. Don't put cold lotion on the patient. Put the lotion on and then wipe off that excess. So all washing is done the same way. Doesn't matter what skill we're doing, all washing is going to be done the same way. Just like every time we clean a basin, it's going to be done the same way. We're going to dump whatever's in the basin where it would normally go. Don't overthink this, guys. If it's bathing water, put it in the sink. We don't put dirty washcloths back in the basin. So it's just water, guys. Put it in the sink. If it's body fluids, elimination fluids, urine, feces, vomit, that type of thing, that goes in the toilet. Don't overthink this, okay? So dump your basin out. Then rinse it. Dump your rinse water wherever you put the basin contents. If you dump the basin contents in the sink, rinse water goes in the sink. If you dumped your basin contents in the toilet, rinse water goes in the toilet. Good? Then we're going to set that basin down. Now, the reason we're setting it down is because if we have to disinfect it, you can't hold it while you're disinfecting it. So we set the basin down so that we can disinfect it if we need to. For the test, we skip that step. Then we're going to pick the basin up with a paper towel, dry the inside, dry the outside, and grab one more for the drawer. We'll collect our soap, lotion, or whatever we have out on our way. Use the paper towel to open the drawer to put our items back in. That paper towel is important, and we talked a little bit about this at the end of last class. Don't touch that drawer front with dirty hands or dirty gloves because that just contaminates the drawer. So at the end of the skill, we need that paper towel to open the drawer. Good? All right. Shoe rules we learned last class as well. Slipper socks are not enough. They don't protect against injury. So if the patient's feet hit the floor, we got to talk about their shoes. I see you have shoes on. Do your shoes fit well? We got to talk about their shoes. If we're going to use a gait belt, when we put it on, it goes over the clothing. You make sure it's tight enough by only being able to fit 4 fingers between the belt and the patient. And we really want it snug because we get skinnier when we stand up. Once we have the gait belt in place, we're going to make sure their feet are flat on the floor. Their hands go on our shoulders. We grab the back of the gait belt or around the sides if they're a little larger. And on the count of 3, remember, you have to involve them. So we're going to count to 3, 1, 2, 3, and we're going to lift them to a standing position. Once they're standing, you want to ask, are you dizzy? Make sure they're okay. If they say yes, sit them back down. Don't try to walk them. I don't care what your care plan says about walking a patient 10 steps. If they're dizzy, don't do it. We don't focus on care plan over patient. Remember, it's always about the patient. So if they say they're dizzy, weak, nauseous, whatever, if they have any symptoms, they sit right back down. We go get a nurse. And I'm going to talk to you a little bit more about that in just a few minutes. There's another part of this I want to go over. But when they're standing, ask if they're dizzy or weak. When we take them for a walk, they should be our entire focus, not our phone, not a caregiver down the hall that we're talking to, not a TV. Your patient should be your focus. Now, the reason for that, Students get this, CNAs get this all mixed up a lot. When we're walking, your patient doesn't just walk along, I'm good, everything's fine. They don't do that. Patients that are going to fall give you all kinds of signs that that fall is coming. They slow down. They get a little wobbly. You're holding onto that gait belt. You will feel that wobble. They'll put their hand out to the wall. They might put their hand up to their head or to their stomach. They are giving you all kinds of clues that something is going very wrong here. It's not, I'm walking, I'm on the floor. It doesn't work like that. And when a caregiver tells me that that's what happened, it tells me that they weren't paying attention to the patient. The only time that a patient will walk along just fine and then drop is with a sudden, massive heart attack. And we got way bigger problems then than a fall. Does that make sense? So if I'm not working on their heart, I know you weren't paying attention. Got it? And yes, you are responsible for that. So your focus when you're walking a patient is to pay 100% attention to that patient. When you get back to the chair, you want to back them up so that their legs hit the back of the chair. They know it's there and you can help them sit. We want to use proper body mechanics. Don't stand directly in front of the patient and pull them up toward you because that pushes you back. Every skill is going to end with the closing. The closing is universal. We do it all the time. You should be able to recite this by heart. Thank you very much, Ms. Jones. Is there anything else I can get for you? Are you comfortable? Would you like a magazine before I go? Your environment's clean, bed's in the low position, and you're covered. Here's your call light. Open the curtain. Wash your hands. Document. And if you've documented, wash your hands again. That's the closing. It's kind of long. There's a lot of steps to it. But it also checks off a whole lot of checkpoints during the test. So a question I get asked a lot during the test is, what if I run out of time? Right? Because we are timed on the test. They're going to give you a specific amount of time to do these 3 skills. What if I run out of time? Well, the answer to that is they always give you a 5-minute warning. Always 5-minute warning. So if you're on your last skill and you get that 5-minute warning and you know that half of your checkpoints are the opening and the closing, don't skip it. Get those checkpoints. Get your opening and your closing done. Get a few steps in between done. But you definitely need to make sure you're getting to that closing in that 5 minutes. This is where your checkpoints are. Make sense? Good? It's a good strategy for the test. You guys shouldn't time out. I haven't had a student time out on the skills test in a very, very long time. It's way more time than you actually need. The average is about 31 to 35 minutes. That's kind of the average to do 3 skills. If you watch all of my videos back to back to back to back to back, right? If you just watch all 20 skills videos, one right after the other, it's just over 2 hours. You've got a quarter of that time to do 3 skills. I'm doing 5 in that time frame. It's plenty of time. Don't rush. Good? Questions? All right, Eve asks, hi, Miss Pat. Thank you very much for helping me to pass both the clinical and written exam. More blessings and good health. Oh, thank you. Congratulations. Great job. Great job. Remember that you have to end the skill with clean hands and a patient who feels cared for and cared about. This is kind of the part that we tend to forget when we get into our daily routines. Remember that it really is all about the patient. And I know when you get into work and you start getting into your routines, it's easy to overlook this because you're just trying to get your work done. It becomes a habit. How many guys work? How many guys have been at your job for more than 3 months? Okay. So the first 3 months, you're a new kid on the block. You're paying attention. You're hyper-focused on everything you're doing. You're trying to make sure it's all right. After about 3 months, you are now in a rhythm, a routine. You can do this. You're not even thinking about it anymore. And you stop paying attention to how you are doing the steps. You're just going off of memory, muscle memory. You're just doing the steps. That's fine if you're packing a box. That's fine if you're making food. It's not fine when you're dealing with a human. Does that make sense? Okay. So, and I saw this in real time when I hired some employees for my retail store. The first couple months, they were awesome. Man, they were helping everybody. They would say, hey, we just got some new stuff in that's built specifically for, people, with your body type. Let me show you. This is something you might be really interested in. And the person would go try it on. They'd be like, this is amazing. It makes me feel awesome. It fits me just right. It was awesome, right? How exciting would it be to go scrub shopping, go in and have somebody say, yep, I know exactly what you need, right? Rather than taking 14 items into a fitting room and guessing and hoping, right? You want that level of service. That's amazing level of service. After about 3 months, they stood behind the register. Yeah, let me know if you need anything. Right? They forgot about the human part of it. They focus on the tasks. I can put the inventory out. I can ring people up. That's what I'm here to do. There's a big difference between those two. And think about if you were the patient, what kind of service would you want? Make sense? Good? All right. Pulse. So when we're taking a radial pulse, remember a radial pulse is located at the thumb side of the wrist. You cannot take a pulse anywhere else for the test because our care plan says radial pulse. When you're taking a pulse, this is the measurement of how many times a heart beats over 1 minute. When you're taking a pulse, you're going to use your fingers, not your thumb, and you want to use your fingertips, not the flat part. You're going to put your fingers over the pulse, which is located at the thumb side of the wrist. Put your thumb on the back, pick a starting point on the clock, and we're going to count what we feel under our fingers for 1 full minute. So until that second hand goes all the way back around to where you started. In Florida, you would count with both evaluators if they're there. If there's only one evaluator, you'll only count with one, but you're going to document. Anytime you count, you have to document. Normal is between 60 and 100. What would I need to do if I got under 60? Report it to the nurse. What would I need to do if I got over 100? Report it to the nurse. Very good. Jen says, I've said this before, but in Pennsylvania, I had to do 5 skills in 30 minutes. I still had almost 10 minutes left, and my partner was under the time limit as well, and she had a little bit harder skills. Thank you, Jen. Awesome. Awesome. So that gives you an idea from somebody who's already taken the test. As long as you have a pretty good idea of how these skills are supposed to be performed, you're not going to time out. Thank you, Jen. Dressing a resident. When we are dressing somebody, they have the right to pick their own clothing. So we're going to ask them what they would like to wear. We're going to get our clothing before we undress the patient. Remember, privacy is going to count here. We're going to pull the curtain and give them a privacy blanket as well for that privacy. We lift from below, supporting all joints as we lift them. We undress strong arm first and dress weak arm first. We straighten the clothing, make sure it's fastened appropriately. The pants are over the hips. The toe seams are lined up. Don't overextend or force movement. Everything goes into the hamper when we're done with it. Their gown, the privacy blanket, everything that we have used in this skill. Call light goes in the stronger hand for this one. Since we have a weak arm, it's part of the care plan, we've got to pay attention to where the call light goes for this skill. Hand and nail care. This is a mini mani. That's all this is. You're going to soak the hand, take it out, put it on a towel to wash it. Put it back in the basin to rinse it, take it out, put it on a towel to dry it. Then we're going to take an orange stick, use the slanted end, bevel up to clean under each nail. We'll wipe it off on the towel before we move to the next nail. We're going to file in one direction toward the center, not back and forth rapidly. We're going to warm up the lotion in our hands, put it on, and wipe off the excess. That's it. Hand and nail care, super easy. I would want this skill. You're going to get one ADL skill. Now, your ADL skills, this is mouth care. So you're going to get one of these that I'm about to tell you, okay? You're going to get one. Mouth care, denture care, hand and nail care, foot care, Peri-Care, catheter care, bedpan. You're going to get one of those. Out of those 7, this is the one I would want. Or, yeah, hand and nail care. That's the one I would want. Out of those 7, that's the one I want. Right? But the one that you dread is the one you get. So start dreading that. Okay. All right. Making an occupied bed. This is a magic trick. We're changing the bottom sheet a half at a time. So we're going to turn our patient over on their side so they take up less room in the middle of the bed. Clean rolls toward me, dirty rolls away. So we'll take that dirty sheet, roll it toward the patient, tuck it up under them, attach the clean sheet corners to the mattress, roll it toward us, tuck it under the dirty. Yeah, I'm getting all, ugh. All right, put them back on their back, go around to the other side of the bed, do the same thing all over again. Put a top sheet on top, get the corners off the floor with hospital corners, change the pillowcase. It's the whole skill. That's it. Just make sure the patient's always in the middle of the bed. Remember, that's important. That's what they're grading you on here. If you've got that patient too close to the bed and you start shoving a sheet under them, what's going to happen? Yeah, they're going to fall. And that's what they want to make sure. That's what they're looking for. So, guys, keep that up, Jake. All of this that I'm going over, by this point, you're rolling your eyes. You're going, yeah, I know. Keep the patient in the middle of the bed, you know. It's kind of, to you right now, it's kind of like boring repetition. But when we can have NICU nurses, these are people that went through 4 years of nursing school and lots of experience to get it. They don't just like hire you in NICU, right? You have to have training and experience. These are people that should be on the top of their game. And you still have somebody who doesn't pay attention and babies get pulled out of the incubator and dropped on the floor. Right? This is something that you and I are going, oh my gosh, that's absolutely horrible. How could anybody do that? Well, they do that because they quit paying attention to the fundamentals. The patient must always be in the middle of the bed. So when I go over this and over this and over this, I'm hoping that these little sayings are worming their way into your brain so that 6 years from now, if you walk into the room and the patient's not in the middle of the bed, your brain should automatically go, danger, danger, fix it. And we have fewer problems with patients. Does that make sense? That's why I do this. All right, if we have to turn a patient ourselves, normally your patients can turn themselves, that's awesome. But if we have to turn them, if they're not able to do that on their own, we have a special process for that. Furthest arm up, closest arm crosses. Closest knee bent, furthest knee angled. If you get a patient set up like this, rolling them on their side takes no effort at all. One hand on the shoulder, one on the hip, and they just roll. Super easy. Doesn't require any force on my part. Now, if I just try to turn her laying in the bed, if I scoot her toward me and then just try to turn her, right, it takes a lot more work. And she tends to do things like this because I haven't set her up properly. What you want to do is move their extremities and set them up so that it's a controlled turn. Good? Okay. Now, once we get the patient on their side, we can use some pillows to keep them there, especially if they're immobile or can't control the roll on their own. One pillow behind their back in a roll, one between their legs, specifically between the knees and the ankles, one under that top arm to relieve the pressure along the upper back, and adjust the one under their head so their arm is under the pillow and it's not under their shoulder. Call light will go in that bottom hand. Foot care, just like hand and nail care, a little lower. Nothing with the toenails. So we put the foot in the basin to soak. We take it out and put it on a towel to wash it. Put it back in the basin to rinse. Take it out and put it on a towel to dry it. We don't do anything with toenails. But we are going to look at this foot, all of the surfaces of this foot, and we're going to apply some lotion after we dry it. No lotion between the toes, but lotion everything else. The whole reason you're doing this, guys, is to look for any problems. It's the whole reason you're there. And this is actually a relatively new skill. This is only maybe 8 or 9 years old, where, you know, the rest of them are like hundreds of years old. This is new. So the reason that we had to do this is because we told CNAs, hey, every shift, I want you to look at the patient's feet. Look at the skin of their feet every shift. And the CNAs didn't understand why we were asking or didn't care. And they'd walk in the patient's room and they go, like, I don't have anything to do. I got to look at your feet. Yeah, you got feet. I don't know why I had to do that. Yeah, they got feet. No big deal. That did not help the nurses. That did not evaluate whether we had a problem to worry about. So because CNAs out there didn't do what we asked them to do, we created a skill. Because we figured if you soak that foot and you wash that foot and you rinse that foot and you dry that foot, and you lotion that foot, somewhere in there, you might actually look at that foot. That is why you're doing this skill. Has nothing to do with getting it clean.
So if we do observe wounds or sores on the foot, we should not put lotion
Yeah.
on.
No, don't put lotion. Don't put their sock and shoe back on. Go get the nurse. And here's why. And this actually happened to me in long-term care. CNA goes in to get a patient up for the day. This is in a work setting. Get a patient up for the day. So she, gave them a bed bath, partial bed bath, cleaned all the high points, cleaned their feet, got them totally dressed, head to toe, socks and shoes and underwear and pants and shirt, the whole 9 yards. Got them sitting in a wheelchair, took them to breakfast, and then tells me, hey, this patient's got a big red area on their butt and they've got an open wound on their foot. What do you need? What do you want me to do about it now? They're sitting in a wheelchair fully dressed at breakfast. What am I supposed to do with that information? So after they eat, get them back to their room, get them undressed, and I'll come take a look. Right? So if you just stop what you're doing and go get a nurse and say, hey, there's an open wound on this foot. Do you want to take a look now before I button it up? That nurse will stop what they're doing and go take a look. Does that make sense? Yeah, that one, I was just like, did you not think that one through? We have to look at it. Make sure when you put that sock on, there's no wrinkles and the shoe is fastened appropriately. Mouth care. Don't overthink it. You're brushing teeth. Just make sure that the head of the bed is up and the pillow is behind the back. Put a towel over their chest to keep their clothing clean. Wet the toothbrush, put a little bit of toothpaste on it and brush what they've got. No time requirement here, just brush what they've got. Let them rinse and spit as much as they need to and then clean up. Make sure when you leave, their mouth is dry. Don't leave them a drippy, wet mess. And then we have respirations. This is an easy one. You're just counting their breathing, but you don't want them to know you're counting their breathing. So we're going to make this look like we're taking a pulse by holding their wrist. We're not finding their pulse. Just hold their wrist. You can put an alcohol pad on their tummy to make visualization easier, especially because the evaluator should be across the room for this, like as far away from the bed as you can get them. And that's where you want them. You don't want them breathing over your neck. So if you put an alcohol pad on their tummy, it makes it easier for those evaluators on the other side of the room to pick it up so they don't have to come too close. Okay. Normal's between 12 and 20. You don't want to tell the patient you're counting their breathing. In and out is going to count as 1. This is a documentation skill. So you're going to wash your hands, document, and wash your hands again. Okay. Range of motion. We've covered a lot of range of motion. We've done shoulder, we've done hip, knee, and ankle, and I'm going to work in elbow and wrist today as well. Range of motion, we lift the extremities from below with a flat palm, 2 points of support. A range of motion has to be a full range of motion, which means we always return to the start position. We move slowly and smoothly. We monitor for pain. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. Those are the 3 exercises that we can do as CNAs. Doesn't mean we're going to do all of them. How do we know which exercises to do? Care plan. Very good. Denture care, variation of mouth care. So denture care is mouth care with an extra step. So we're going to take that cup full of dentures over to the sink. We're going to put a washcloth in the sink. Remember, we need gloves on when we're handling dentures. We're going to use cool water and we're going to brush the dentures, being careful not to drop them or lay them down in the sink. After we've washed the dentures, you're going to clean the cup out by rinsing it out, filling it up with cool water, putting the dentures in and a lid on. Put a paper towel underneath it and put it on the bedside cabinet for them to use later. Put your washcloth and dirty linen. Bring your denture brush and basin back to the patient, and now you're going to do mouth care. Once you get back to the patient, you can remove your denture gloves, get everything set up, and put your mouth care gloves on. Okay, good. Ambulate with a gait belt. This is just walking somebody. Super easy. The evaluators are going to give you a specific destination. Walk to that table, walk to the door, walk to, they'll give you a destination. Just follow their directions. It's going to be about 5 steps in one direction. You'll turn 5 steps back. When you're ambulating somebody, all those shoe rules are going to apply. You want to make sure their feet are flat on the floor. They have shoes on. You're going to put the gait belt over the clothing, fasten it so it's snug. You should only fit 4 fingers between the belt and the patient. You're going to use that body mechanics, 1 foot in front of their feet, 1 foot beside their chair. Have them put their hands on your shoulders, grab the gait belt around the sides or the back, and on the count of 3, you're going to stand. Once they're standing, ask them if they're dizzy. As you start to walk them, pay attention to them. If your patient starts to fall, if you're walking and you're paying attention to that patient and they get a little wobbly on you, or they put their hand out, or they go, oh, I'm not feeling right, you need to get them sitting on the floor right now. Do not rush them back to their chair. They aren't tolerating a slow walk, people. What makes you think they're going to tolerate a rush? Nobody tolerates the rush. So you want to get them sitting on the floor, because a patient sitting on the floor can't fall on the floor. Falls are where injuries happen. Sitting them on the floor, no injury there. I'm controlling that descent. And I don't care about them sitting on the floor. I got soap and water. They can wash off whatever they come into contact with. So if I'm walking somebody and I'm in the right position, which is slightly behind and to one side, I've got that gait belt. My focus is on that patient, which is just slightly ahead of me. As we're walking, they get a little squirrely on me, right? I immediately, now look at where my legs are. Okay, I've got my patient here. I immediately take this foot and plant it right in between their feet. This hand grabs the gait belt. So I've got 2 points of support on this gait belt, and I pull them against my body. They're leaning against me. And I tell them we're going to slide to the floor. Slide with me. 1, 2, 3. And we slide right down my leg onto the floor. Okay. And then we stay with the patient, send somebody to go get the nurse. Good. Don't rush them back to the chair. They will not make it. All right, so we're going to hold the back of the gait belt in an underhand grip. We always let our patient lead. We want to ask them along the way how they feel. We're going to help them when they stand up, but we're also helping them when they sit. We want that stability with that gait belt. And don't pull that gait belt against their clothing or their skin. You want to just loop it up and around. All right, and then we learn partial bed bath. Now, we use this leaves method with partial bed bath. And if you remember, our care plan was face to waist, front and back, one arm and hand. So we're going to wash the face first, no soap, and we're going to use that leaves method because we have wet body openings on the face. So one leaf for an eye, fold it over. One leaf for the other eye, fold it over. One leaf for the rest of the face, hold it over, and one leaf for the nose. We'll set that aside. We're not going to reuse that. It's got boogers on it. Dry the face. Then you're going to wash the front of the body. You're going to rinse the front of the body. You're going to dry the front of the body and put the new gown on. Scoot them towards you, turn them over, wash the back, rinse the back, dry the back, little back rub, tie the gown, and clean up. That's the skill. You want to make sure you're protecting the bed with this, though, because we're going to be washing the body on the bed, so put a towel down. Protect the bed. Nobody wants to sleep on clean sheet or wet sheets. They won't dry. All right, any questions on all that? Whew. Did I do it? I was hoping to do it in 30 minutes. We did it in 40. Pretty close. So the first 40 minutes of class 6 is your final review. Everything we've learned up to this point. We will not have a review on Monday. All right. Good. Okay, our next skill is going to be on, go back a page, Jake, please. Page 72, this is our overview. Transfer out of bed and into a wheelchair. This is going to look a whole lot like ambulating. So the first part of ambulating is what we're going to do for transfer. We're going to make sure they have shoes on and their feet are flat on the floor. We're going to put our gait belt over their clothing, make sure it's snug enough with 4 fingers. They're going to put their hands on our shoulders. We're going to use that same body mechanics, 1 foot in front, 1 foot beside. We're going to count to 3 before we lift them. When we turn them, we want to make sure they can feel the chair behind them. All of that is the same. That's all the same. What's different here is that we're not walking the patient. We're just picking them up, turning them, and sitting them down in the wheelchair. So we have to learn a little bit about wheelchairs with this particular skill. So if you look down here, you can see all the principles are all spelled out for us here. Test-specific information is down at the bottom. Guys, they're giving you 11 minutes to get somebody out of the bed and into the wheelchair. 11 minutes. I do this in like 3. Even if, you know, you put your whole opening and closing in there, maybe 4. This is not a long skill, okay? Person's going to be, it's a live testing student, so one of you guys will be a patient for this. And for the test, they try to match you up with somebody that's your body size or smaller whenever possible. Even better if they can find somebody your body size or smaller that has slip-on shoes, because that just makes it a little bit quick. Where do those evaluators want to be? Home in their pools, drinking their margaritas, right? They don't want to be watching you fumble with shoes. You know, everybody knows how to tie shoes at this point. So they try to speed this up a little bit. Good? Good. All right. So our care plan's at the top of page 73 here. It tells us to transfer the resident from bed into the wheelchair. The resident is unable to walk or take steps. I'm going to time out here. I want you to take a pen or a highlighter, whatever you got, and I want you to underline that. Unable to walk or take steps. Unable to walk or take steps. So during the exam, if the person playing the patient has to take a step to get to the wheelchair so they don't fall, did you follow the care plan? And what do we know about our score for the test if we don't follow the care plan? Yeah, you fail, right? And it's not, and this is where students get so confused. It's like, well, I just missed 1 step. Why did I fail? I just missed one step. Because your patient can't take a step. They can't. You force them to do something that they physically cannot do. So if you've got somebody in a clinical setting that physically cannot move their leg to take that step, and that wheelchair is too far away, they're not going to take the step. So what's going to happen to them? They're going to fall. That's right. So by missing that, by forcing somebody to take a step, that tells us that out there, patients are going to fall. Do you guys see that? It's not about the steps. It's never about how many steps you miss. The test will never be about how many you miss. It's about what did that missing step, what impact did it have on the patient, and what will it have on future patients. Make sense? Okay, it goes on to say, but can stand with support. So that's good. That's good. They can stand. So you're not holding their whole body weight. They can stand. They just can't take steps. A gait belt or transfer belt is required to transfer the resident, and the resident will stay in the room. So that's our care plan. Tells us what's going to happen after we get them in the wheelchair. Guys, I want you to understand that these scenarios, these care plans are a snapshot out of the patient's day, just a sliver of time. Think of it like a scene to a movie. You don't really get to see what comes before and after. It's just a scene in the movie. So we're going to put a patient in a wheelchair. They're just going to stay there. The scene over, cut, end, whatever you want to say there. But would you, as a patient, want to be staring at a wall?
No.
No. So when we get a patient in a wheelchair and we know they're going to stay in the room, because that's what our care plan says, what direction do you think they should be facing?
They should be facing to the TV.
Yeah, TV, window, door, something, not the wall. Now, this is especially important in older individuals. Anybody know what a common punishment was for old people when they were kids? In the corner. That's right. Face the corner, face the wall. That's right. So when you put a patient in a wheelchair, particularly an older patient, and you face the wall, how do you think that they're going to feel? Yeah, they're going to feel like they're being punished. That's right. So it's such a small thing, but it has big impacts on our patient. So for this skill, just turn the wheelchair around, have them facing outward. Okay, give them something interesting to look at. Step-by-step instructions are here. And for number 18, you can see big, bold letters here. It says the patient cannot take steps. Very important. Oh, go back, Jake, one. All right, I want you to look at this graphic down here. Now, I'm the one that made this graphic. The next edition, I'm going to change this. Do you see this graphic? Do you see how close that wheelchair is? It's still too far away. It is still too far away. That patient, if I stood that patient up and swung them around, they're still more than a foot away from that wheelchair. When you put that wheelchair there, you've got to get it almost, that you should only be able to fit a piece of paper between the patient and that wheelchair. That's it. That's it. This right here is all the space you should have. This is all the space you should have between the patient and the wheelchair. So this, although it's good for illustration, understand that's not even close enough. Go ahead, Jake. All right, so all of our shoe rules are going to apply here. We're going to make sure the patient has shoes. Of course, they start out in bed. They're not going to have any shoes on. So we're going to swing them around in bed. And we're going to get them sitting on the side of the bed. And we're going to put their shoes on, making sure their feet are flat on the floor. Make sure the bed is in the lowest possible position for this. Now, I'm going to show you a way of swinging somebody around to sit on the side of the bed that really doesn't take much effort. But there's another technique you can use, and I don't normally show this. I'm going to be making a video on it that is really cool. and it can help, especially when you have larger individuals. You take a sheet, one of these sheets, top sheet, and you fold it in half lengthwise, not this way, this way. Okay, so you fold it in half lengthwise. And then you fold it in half again if you've got a smaller person. Okay, so fold it in half lengthwise. And you put it underneath their back, okay, underneath their back, right around their shoulders. You want just a little piece over here, just a little tail over here. And I'm sorry, you want the longer end over here, a little tail over there. You wrap the longer tail over their torso and under their legs. And when you do that, if I'm standing here, I grab this tail, and I just turn them. It creates a sling that turns the patient. It is super easy to do. Now, I usually don't do that if I don't have somebody that's really large. I don't think I can handle on my own. It's way easier for me to just put my hand under their shoulders and over their legs and just turn. Okay. Good? Make sense? I'm going to do a video on that. You won't use this on the state exam. In fact, our care plan doesn't allow us to use this on the state exam. But it's just something I want to plant for later, because you'll see other CNAs do it, and it's very helpful when you have somebody that's very large. Okay.
Sorry, I was trying to close it and it won't. I think the door frame shifted or something.
It's probably warped from all the heat. Okay. All right. So once we get the patient sitting on the side of the bed, we get their shoes on, their feet are flat on the ground. Go ahead, Jake. Go ahead. Remember, slipper socks are not enough. We're going to get our gait belt on. Now, it doesn't matter which way you do this. You want to put the shoes on first? That's fine. You want to put the gait belt on first? Go for it. Nobody cares. That doesn't matter. It's not a tested checkpoint. Just make sure before you transfer them, you've got a gait belt and shoes. That's all they really care about. When we put the gait belt on, we want to check it with those 4 fingers before we lock it into place. Feet flat on the floor before we stand them. And we're going to count to 3 before we lift. Remember, we're going to grab on the back of the gait belt. Use that body mechanics as well. Now, before we sit that patient down, we need to know that they can feel that chair. Here's the problem. Our care plan says they can stand, right? They can't take steps, but they can stand. But the person that you are doing this on for the test probably isn't going to. They're just going to kind of be dead weight. Try not to do that to your person that is using you, for a patient. But if I lift somebody up and I turn and I have to go through this, can you feel the chair behind you? And they have to think, yes, I can. And then I said, that's a whole lot of time to hold that patient. That's hurting my shoulders, my upper back, my arms. So I do something a little different. I tell them, okay, I'm going to lift you and swing you. When you feel that chair behind you, say sit. Put your hands up here. Okay, remember, when you feel that chair behind you, say sit. Ready? 1, 2, 3. Up, over, sit, down. Speeds the whole thing up. Good? Good. Okay. So remember, they are unable to walk or take steps, but can stand with support. When we start this skill, we've got to get the patient sitting on the side of the bed. They're laying down when we start. We're going to get them sitting on the side of the bed. If we have this wheelchair really close, you're not going to be able to get them to sit on the side of the bed because their legs are going to hit that wheelchair. So your wheelchair has to be kind of away from the bed at the beginning of this skill. You're going to get them sitting on the side of the bed, get their shoes on, gait belt, and then we can bring that wheelchair super close. I should only be able to fit one sheet of paper in between. We're going to lock that wheelchair, and then we can transfer them. Okay? Now let's talk about wheelchair locks. Every wheelchair is set up a little bit different, but there's two main kinds. This one, this side is unlocked. You can see this is the bar, this is the wheel, there's a gap there. That means it's unlocked. The lever is in the forward position when it's unlocked. If I pull the lever back, it presses this bar into the wheel. You see that they're touching. Now we're locked. So this wheelchair, you pull it back to lock. Other wheelchairs, you press it forward to lock. For the test, they're going to show you what kind of wheelchair you've got to work with. Okay? But just remember, locked doesn't rely, we don't care which position the lever is in, is this bar pressing into the wheel. This is locked. Doesn't matter what this lever is doing. I don't care about the lever. Is the bar pressing into the wheel? Now, wheelchairs have to be locked if they're not currently in motion, and that's because floors are rarely completely level. Concrete floors warp. They settle, they crack. You can end up with little, bumps and stuff. And wood floors definitely warp with humidity, just like our door. So if we have a patient in a wheelchair and it's not locked, and that wheelchair starts to roll, the only thing that's going to stop it is whatever they run into. And that can risk injury. So anytime we have a patient in a wheelchair, it should be locked. Your patient can unlock it and go wherever they want to. It's not a restraint. They can go anywhere they want to. If they can't unlock it, well, then it definitely needs to be locked. Because if they can't unlock a wheelchair, that means they can't stop a roll. Good? Let me show you how important this is. One of the largest negligence verdicts in Florida happened in 2004. Now, there's been bigger negligence verdicts since this, but one of the largest happened in 2004, and we had a dementia patient who was strapped into a wheelchair, which is illegal, by the way. You're not allowed to strap somebody in without a doctor's order. She was able to access a stairway. Somebody left the stairway door open. She got into the stairway and ended up going down concrete steps, strapped into a wheelchair. She died. She died. Now, this is a multiple part failure, right? A lot of things happened here that led to this outcome. But let's think about why a patient might be in a facility. Dementia patients. Families generally keep their people at home until they get to a point that they need care beyond what the family can provide. So that means the family goes looking for a facility that can care for their loved ones better than they care for them at home. You guys understand that? They are trusting strangers to provide a higher level of care than what they could provide at home. Now, the reason that we put dementia patients in a facility is to keep them safe. Safe. Because caregivers at home would have to stay up 24 hours to keep your grandma safe if she has dementia. You just can't keep up that kind of a schedule, so we put them in a facility with the intention that the facility is going to do the right thing. Did this facility keep our patients safe?
No.
No. And that's why it was one of the biggest verdicts. Because the family is going to suffer with guilt for the rest of their lives if I had kept mom at home. She probably wouldn't be dead. You guys understand that? We have to remember why we are being entrusted with these families' most precious items. Okay? It's a trust thing. Okay. All right, so wheelchair brakes are not a restraint. They're there for safety. If your patient can self-propel, they can unlock that wheelchair, go anywhere they want to. They can stop or roll if they're in a dangerous situation. If somebody cannot stop or roll, they're going to get injured. So if they cannot unlock their wheelchair, they cannot stop or roll. Therefore, they're going to get injured. So if the wheelchair has a person in it, it must be locked. Good. It also has to be locked when we're putting somebody in and taking somebody out so it doesn't roll away while we're doing those two things. Now, this next story I'm going to tell you is super sad. Go ahead. Oh, we're not there yet. Okay, that's okay. We'll get to the super sad story in a minute. So those that are unable to control a wheelchair, either because of physical or cognitive issues, have to have their wheelchairs locked. Go ahead. Now, I want to talk to you a little bit about these foot pedal things. And these get lost in facilities all the time. They come off. They just lift right off. Jake, can you go get me the wheelchair? Thanks. They just lift right off. They get lost all the time. But there's a problem with that. If you look at this, this is the seat of a wheelchair. This is the seat of a regular chair. Do you see how there's a height difference? Well, that's on purpose. The whole purpose of a wheelchair is to push somebody somewhere. We don't want their feet flat on the floor. Keeps us from pushing them somewhere. So wheelchair seats are always higher, thank you, than regular seats. Now, what that means is because you've got this seat height difference, that wheelchair, because it's taller, the legs are going to dangle. Now, dangling legs are actually a danger. Go ahead, Jake. And that's because of this. These are the arteries and the veins that run along the backs of the legs. And right here at the back of the knee, there's a whole lot of veins and arteries that all kind of come together. So it's called the popliteal space, and it's highly vascular. A lot of blood vessels in there. Well, when we sit in a wheelchair, go ahead, that seat presses right up into that area that's highly vascular, and that is going to collapse those blood vessels. It squishes them closed, especially if the legs are just hanging. Good? Makes sense? So if you have these blood vessels that are squished closed, well, what does that do in the body? Go ahead. It causes swelling because the fluid can't get back up to the heart. So when we have patients without those footrests, you'll probably see lower extremity swelling, but there's a bigger risk than this. This is bad enough. It hurts. This is very painful. Swollen legs can be very painful. It hurts, but there's something way worse than this, and that's this. When blood slows down or stops, it clots. This is an immutable principle. This is a physics principle. When blood slows down or stops, it clots. Well, inside the veins, because veins have to bring blood up, right? Gravity's pulling it down. We have to get the blood back up to our heart. So this is a back and forth, a tug of war. So inside your veins, you've got these little valves. And as your heart beats, the blood from this section gets pushed up into this section. And to keep it from falling back down, you've got these little valves. Good? Well, when these valves are in the back of the legs that are being squished down, they're squished closed. So the blood isn't going to be able to get up here. And that means it's going to slow down or stop, which means it will clot. What is our patient at risk of? Blood clots. Blood clots can kill your patient. If they travel back to the heart or the lungs, it can kill your patient. So when we have a patient in a wheelchair, you have to have those foot pedals out for the legs to rest on. That relieves the pressure on the back of the knees, opens up those blood vessels, and we reduce swelling and the potential for blood clots. Good? Questions? Good. All right. So these leg pedals, leg rests and foot pedals are super important. If your wheelchair is missing them, we got to go find them, or you got to let the nurse know, or we have to put a broken sign on it and not use that particular wheelchair. And let me show you how easy these things are. That's it. Now, if I go put this in a room somewhere, lay it down, we may never find these things again. It's that simple to remove. They just hang on two little metal protrusions here. There we go. And then they clip into place. Good? Okay. Don't ever use a wheelchair without the feet being supported. Go ahead. Okay, so there's two parts to this. There's the leg rests themselves, and then there's the foot pedals. Foot pedals hold up and or fold up and down. Leg rests swing in and out. So on the back of the leg rest right here, where it attaches to the post, is a little catch. You just pull the catch toward the middle. Those leg rests will swing out of the way. To bring them back to the forward, this is the position we need to be in to get somebody into or out of the wheelchair. We want it wide open. Once we get somebody into the wheelchair, we want to bring these forward. They just snap in place. Good. Foot pedals just fold up and down. It's just fold up and down. Okay. So these three graphics show you how the wheelchair should be positioned for these three activities. When a patient is in the wheelchair, the leg rest should be forward, the foot pedals should be folded out, supporting the feet. So somebody in the wheelchair, it should look like this. When we're storing it, we're just going to fold the foot pedals up. Keep the leg rests forward, because if the leg rests are just kind of out there floppy, as you're moving this thing to storage, it can hit somebody. You want the leg rests forward, foot pedals up. This is the position it should be in when somebody's getting into or out of the wheelchair. These things should be out of the way. You might have a test question like this that shows you three graphics and asks you which position is proper to transfer a patient into a wheelchair. Remember, wide open is what we want. Go ahead. All right, so this is a super sad story. And I feel so bad for this worker. I mean, I really do. I feel so bad for this worker. So this is the kind of the gist of the situation. This older woman went to the hospital to have some x-rays done. And she was in a wheelchair while she was there because she had trouble walking. So they just used a wheelchair to get her to radiology. She's ready to go. Her daughter goes out and gets the car and pulls it up front. Transporter was supposed to come bring the woman out to the car and help her in. No big deal. We do this all day, every day. But the transporter was tied up. Didn't come. So the daughter is sitting out in the front driveway at the front door holding up traffic. No transporter. And there's a receptionist who thinks, oh, well, I can help with this so that we can get traffic moving again. I mean, her heart was in the right place. So she grabbed the wheelchair. She says, I'll take you out to the car. She takes the woman out to the car, but she had not been trained on how to use a wheelchair. She did not lock the wheelchair. She did not move the footrest. She just took the patient out to the car. As the old woman was trying to get out of the wheelchair and into the car, there's a whole lot going on here that she couldn't step over. And she ended up falling. And when she fell, she broke her leg. Is she going home? No. Do you know who was held responsible? Why? Okay, her responsibility, but she had not been trained. We tend to look at these things and go, oh yeah, I know how to use that, right? They're super easy. They're a chair with wheels on it. How much training do you need? Clearly, more than she had. The problem is that you don't know what you don't know about a topic. She didn't know that you had to fold the foot pedals up and get the leg rests out of the way. She didn't know that she didn't know that. And that's what put the patient at risk. This is why you have to be trained on everything, because there's some part that you just don't know. Does that make sense? Now, I feel super bad for this worker because she was trying to do a good deed. She was trying to do a good job, and I feel so bad for her. Oh, that's why. Got it.
Oh, the lock was out?
The lock was out.
Didn't even look like it.
And I feel so bad for her. But no good deed goes unpunished. I really feel bad for the patient who thought she was going home. I feel bad for them. Okay. All right. So when we're going to transfer somebody into a wheelchair, you want to fold those foot pedals up, get those leg rests completely out of the way. And then we're going to bring that wheelchair super, super, super close to the patient, almost touching them, and make sure that wheelchair is locked. Go ahead. So we got to get the patient sitting up on the side of the bed. And we want to do that before we move the wheelchair close. So you've got some leg room. Once you get the patient sitting on the side of the bed, go ahead. We're going to get their shoes on, make sure their feet are flat on the floor. Then we're going to get the wheelchair super, super close. And it's actually a little bit closer than this. Super, super close. And we'll get that gait belt on. We don't care what order you do these things. Okay. Put the shoes on, put the gait belt on, get the wheelchair close. However you want to do those three things. It's fine as long as all of them are done before we lift our patient up. Go ahead. When we go to transfer, that wheelchair has to be locked. If I try to put somebody in this wheelchair and it's not locked, it's going to roll away. It doesn't take a whole lot of force. As soon as their legs hit that wheelchair, that's what's going to happen. And then your patient will end up on the floor. Lock those wheels. Gait belt should be on. We're going to use that same body mechanics. And then we're going to lift our patient to a standing position. When we turn them, they've got to be able to feel that chair behind them before we sit them down. So I try to warn them in advance. And then we'll control the descent, the lowering. After we get them in the wheelchair, put their feet on the foot pedals. Make sure that the leg rests are in place, feet on the foot pedals, and we can take that gait belt off. Make sure the wheels are locked. Gait belt comes off. Again, the order of this part does not matter. You can do the foot pedals, you can do the gait belt, you can do the wheelchair lock, however you want to do it. Nobody cares. And then make sure that they're positioned properly in the chair, hips against the back, facing not the wall. That's it. And do our closing. Now I'm going to show you the, normally I do this one live, but my knee is killing me today and I can't torque. So I'm going to show you the video for this one, but I'm in the process of redoing this video. I don't like this one that I'm going to show you, and this is why. So I'm going to bring it up in advance so you know what to do. In this video, when I lift the patient up and swing him around, I just drop him in the wheelchair. I don't want you to do that. It's got to be, he's got to know the wheelchair is there. Remember, we want to hear that and we want to control that lower. So keep that in mind when you're watching this video, that the lowering into the wheelchair could be done better. Okay, good. Questions? All right. You guys will have a chance today to practice with the actual wheelchair. All right, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to get you up and into a wheelchair. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get your supplies, and I'll be right back.
Okay.
Okay, Mr. Jones, I'm going to pivot you around so you're sitting on the edge of the bed. I'll need you to scoot toward me first, if you would, please. Okay, and I'm going to ask you to cross your arms over your chest. I'm going to put one arm behind your shoulders, maintain a wide stance, and put the other arm over your knee. And on the count of 3, I'm going to pivot you. Ready? 1, 2, 3. Are you comfortable?
Yes.
Okay, can you sit up straight for me, please?
Yes.
Are you dizzy at all?
No.
Okay. I'm going to assist you in putting your shoes on. Are your feet securely in your shoes?
Yes.
And are your feet flat on the floor?
Yes.
Okay, let me get a gait belt. I'm going to place this gait belt around your waist, and this is going to help me lift you and pivot you into the wheelchair, okay?
Okay.
I'm going to place this around your waist. Go ahead and raise your arms, and then you can relax. We'll make sure that there's 4 fingers between the gait belt and the patient, and then lock it into place in the second guard. Let me get the wheelchair. I'm going to position the wheelchair next to the bed so it's at a slight angle, almost touching the patient, and we'll lock it into place. Okay, Mr. Jones, can you bring your feet together and slightly back? Thank you. I'm going to ask you to put your hands on my shoulders. On the count of 3, I'm going to lift you, pivot, and sit you down in the wheelchair, okay?
Okay.
Go ahead and put your hands up here. And on the count of 3, 1, 2, 3. Thank you very much. Are you comfortable?
Yes.
Okay, I'm going to remove the gait belt. Can you lift your arm, please? Thank you. Okay, I'm going to unlock the wheelchair and swing you around. Okay, Mr. Jones, I'm going to lock the wheelchair in place. And then I'll position the leg rests and foot pedals to support your legs. I'm going to lift your foot. I'm going to lift your foot. There you go. Okay, Mr. Jones, here's your call light. If you should need anything at all, please let me know. Are you comfortable?
Yes.
Can I get you any reading material?
No, thank you.
Okay, I'm going to open your privacy curtain and wash my hands. Thank you.
Thank you.
After washing my hands, I'll think about all the steps of my skill, make any corrections, and tell the evaluator my skill is done. His face at the end of that. That one was, these were done in 2016, so it was quite a while ago. But that was the very last skill we did, and we had to go back and retape portions of it like a couple of days later. So by the time we got to that point, he was done. Done. The new, I'm just going to put this over here for you guys later. The newest videos, when we retaped them just a couple months ago, I'm in the middle of editing them now. But the newest videos, we did a lot of bloopers. So I'll be releasing a blooper reel on my Instagram at some point. So you can kind of see some of the behind the scenes. It's madness when we're doing, because it's just the 3 of us. We don't have a production company. It's just Jake. He handles videography, lights, and sound. Josiah, who is my patient, and me. That's it. So it's chaotic. A lot of fun, though. All right, feeding a resident in a chair. This is on page 108. All right, so I'm going to give you guys a choice. This is going to take about 45 minutes, this lecture. So we can take a break now before we get into this lecture. and get our break over with, or we can get into the, because I don't want to break this lecture up. Once I get into it, I want to go through it. So do you want your break now, or do you want your break at 45 minutes? Now. Okay. Let's go ahead and take your break then. Come back in 15 minutes.
69, slide number.
Thank you. Thank you. There we go. Great job. All right. So one of our class got second place on the game show yesterday and got the card game. So congratulations. Okay. You guys ready to learn about eating? This is not a hard skill to teach. Most of you guys have a pretty good idea of how to feed another human. It's not, it's not overly difficult by any means. But there's a few things I need to bring to your attention that may not be intuitive. Okay. So if you look at page 108, you can see all of the principles involved in this skill, and they're all spelled out for you. At the bottom of the page, you can see your test-specific information. Somebody with your level of experience should be able to do this in 9 minutes or less. This is a live testing, a live student skill. So that means a live person is going to be sitting in a chair at an overbed table just like this for the test. So this is how they will be set up. That person, whoever the patient is going to be, is going to get very specific instructions from the evaluator. Let me do this here. Sorry. Very specific instructions. And one of the things that they're going to tell them is to slump or slouch. So they're going to say, go sit in the chair and either slump or slouch or just don't sit up straight. Well, your idea of slumping and mine might be a little bit different, right? So because of that, the care plan is actually going to tell us that this patient is in an inappropriate position for eating. So it doesn't matter what your eyes tell you, you've got to ask this patient to sit up straight. Does that make sense? Doesn't matter what your eyes say. So that's kind of the first thing that we have to go over. The second thing is when you're the patient for this, you are going to be told to only take 4 bites and then say you're done. Refuse anything else. So for the test, you're only really feeding somebody 4 bites of food. And the spoon should only be half full. So you're only giving them a little bit of food for the test. Now, this is going to be a single serve food item, whether it's pudding, which is usually what they use, or applesauce. It'll be a single serve food item, one or the other. If you have an allergy that would keep you from being a patient, please let the evaluator know. If you're on a specific diet, please let the evaluator know if that's, for instance, if somebody's on keto, right, putting in applesauce would throw them out of keto. So they would want to let the nurse know, hey, I can't be a patient for feeding because, I can't have those items. Does that make sense? But if that doesn't apply to you, then try to be a patient because it's really hard for those evaluators to figure out who to match up with who. And the more complex this gets, the angrier they get. It's just because we're making it hard on them. They want to be at home. Good? Does that make sense? All right. So 9 minutes is what we have to give 4 spoonfuls of food. It's not a long skill. But there's a few things that we have to know about this. So go ahead, Jake. If you look at the top page 109, you can see the care plan. And it tells us to feed the resident a snack who's unable to feed him or herself. The resident is sitting in a chair in an inappropriate position for eating. Document the intake on a food and fluid intake form. So that's our care plan here. And the care plan specifically tells us this patient is not in an appropriate position. I don't care what your eyes say. Make sure you ask them to sit up. And it's just that simple. Just ask them to sit up. That's all we have to do. But I want to talk to you about that part of the care plan. In a clinical setting, your care plan is not going to tell you that the patient is in an inappropriate position. It won't be on a care plan anywhere. The reason that it's on the care plan here for the test is because they have to have something to point to if you don't ask the patient to sit up straight. Okay, so this is more for test administration. It's not going to be on a real care plan out there. You're responsible for looking at the patient. This can get really tricky. Has anyone ever seen a 10 or 12-year-old kid? 10 or 12-year-old kid? They all eat like this. You put a 10 or 12-year-old kid at a table and give them a bowl of cereal, and this is how they're going to eat it. It's like their head is too heavy. I don't know why, but 10 and 12-year-olds, this is their eating position. So if you have a 10 or a 12-year-old in your vicinity, this is going to look like a totally normal eating position to you. Is it?
No.
No. So we have to understand that the test sometimes has to give us more information than we would normally get in a clinical setting. So in a clinical setting, just look at your patient, try to get them sitting up as straight as possible for digestion to make sure that we're not putting our patient at risk for aspiration. Aspiration is the term that means to breathe in food or fluid. So it goes down the wrong pipe. Good? Good. All right. So at the bottom of the screen, you can see your supplies there. You're going to need some sort of a clothing protector. We don't call it a bib because this is a adult. So we don't call it a bib, just clothing protector. We're going to need a hand wipe. And our tray is already going to be prepared for us. So you'll have a little food tray that's going to have pudding or applesauce, a spoon, a fork, and a cup of water already on it, ready to go. You don't have to make the tray or anything like that. It will have a spoon or fork. We are feeding pudding or applesauce. Which one do we want to use?
Spoon.
A spoon. That is a graded checkpoint. How many people are out there using forks for pudding or applesauce? I don't know. Why they have to make that a graded checkpoint? I don't know. That to me is a little bizarre that has to be a graded checkpoint, but there you go. Use a spoon. All right. So this skill is different than all the other skills we do. It does not follow our normal patterns, our normal rules. We don't close the privacy curtain when we feed a patient. You do not close a privacy curtain. Now, the reason for this is eating is a social skill. We gather in groups to eat. In fact, almost all of our major life milestones are centered around food. Think about birthday parties. There's always food. Weddings, there's food. Funerals, definitely food. Baby showers, engagement parties, graduations, always food, right? So we have to think about eating as a social event. A lot of times we go out to eat, right? And we eat in the company of a ton of strangers. We gather in groups. So eating is socializing. We don't talk while we are chewing, but we do talk while we are eating. There's a difference there. When you walk into a restaurant, let's say that we all go to Cody's for lunch today because it's buy one, get one fajitas. Sounds good to me, right? So we walk in there. Is it going to be dead silent when we walk in? No, people are going to be talking. Even though they're eating, they're talking. They're not eating or they're not talking when they're chewing. They're talking after they swallow while somebody else is chewing. And we tend to forget this fact that people have conversations while they eat. So we don't want to close that curtain and isolate the patient because that will actually affect their appetite. We saw this in real time during COVID. We saw this. Nationally, long-term care patients, assisted living and nursing home patients lost, I think it was nationwide, I think it was something like, I don't remember the exact statistic, but it was something like 10% of body weight was lost in the long-term population during COVID. So socialization is a very big part of eating. If you're trapped in your room with no socialization, you're just not going to eat very well, and you tend to get depressed. So we don't close the privacy curtain for this. In fact, if our patient can go to a dining room, that's the best place for them, congregate dining. But it's also up to you to fill that role as well. So not only are we not closing the privacy curtain, we're actually going to have a real conversation with this patient. For the test, you can make something up. But in a clinical setting, you really need to have a conversation of some sort. So something like they're showing a movie on the big screen later. Are you interested in going? Or activities said the bingo jackpot's up to like over $2 now. That's just crazy. Are you playing today? Something related to the facility is perfectly okay to talk about. But you can also talk about the patient themselves, especially if you're in their room. Look around. People display pictures of things they're willing to talk about. We don't take our deepest, darkest secrets and plaster them on our walls. If it's a picture that's posted, they're willing to talk about it. I used to have, I don't have it up here, but I used to have a picture of myself and my husband on a cruise ship up here. That means that I'm willing to talk about cruising. I'm willing to talk about that picture. I am a big cruiser. I love to cruise. I've been on 30 cruises. That's my downtime. It's one place I can get away from the phone. I leave my phone at home. So I love cruising, and I'll talk about it all day long. So if I'm being fed and there's a picture up there, certainly feel free to bring it up. Do you know where that picture was taken? Was that your first cruise? Do you like cruise? I mean, that gives us a whole opportunity for conversation. With most older people, you'll see a picture on a wall, usually an old black and white photo of a woman who was dressed to the nines. These women put us to shame. They put us to shame. And usually the man is in uniform. When I see that on the wall, I generally will say something to the woman like, oh my gosh, they're gorgeous. Did you know them? Were they movie stars? Watch her sit up a little straighter and say, oh no, honey, that's me. So what did I just do? First, I made a connection. I started this out on a positive note, but she's also going to eat better because I made her feel good. But it gives me an opportunity to ask questions about the picture. Wow, where were you? When was that? Can you tell me about your life together? Right? We got a ton of topics now for conversation. So don't discount the things that are posted around the patient's environment. They can be great for conversation starters. Get to know your patients a little bit. Treat them as humans. I've met somebody who was knighted by the Queen of England. That's a big deal. I met a major league baseball player. And I didn't know it at the time because I don't follow baseball. The name made absolutely no sense, no impact on me at all. I was just talking to him. And so, what did you do for a living? What was your occupation? Really? Really? Tell me about that. How interesting is that? I have met an engineer who was part of the Apollo mission. So there's people in our community, guys, that have a past that is insanely interesting. All you got to do is open up a little and let them tell you their story. Feeding somebody gives us the time to sit down, slow down, and find out a little bit about our patients. But sometimes your patients will surprise you. The most interesting conversation I had with a patient was with somebody who did not think that they had anything to offer with this conversation. I was doing wound care on a patient up in Citrus County in one of the assisted living facilities. This woman was in her late 90s, in assisted living, still with it, sharp as a tack, but needed some daily help. And I was doing wound care on the legs. And this was extensive wound care, 30, 45 minutes, and just a very long time. So I pull up a chair and I'm unwrapping the bandages and I've got to talk to her. We're not going to sit there for 45 minutes in silence. That's just rude. So I asked her one of my favorite questions to ask patients. What's the most exciting place you've ever been? Her response was, oh, honey, I've never been anywhere. So she thinks this conversation is over. She has nothing to contribute. She's never been anywhere. So my antenna pops up at this. Remember, I'm in Citrus County now. This woman's in her mid to late 90s. I said, you've never been anywhere? You've never been to Ocala? She says, no, I've never left the county. And then she thought for a second. She says, well, that's not entirely true. I was born in Brooksville, but I don't remember that because back then, Citrus County did not have a hospital. Everybody from Citrus County was born in Brooksville. We had a small hospital. It's now an assisted living facility. That was the hospital for Citrus County. And I said, you've never, ever left Citrus County? She says, no. I'm pulling up a chair now. This is living history, 90-something years, and she has never left the county. Do you know what changes she has seen in that county? This is stuff you can't even get in a history book. This is fascinating. So I settle in. We're going to have a long conversation. She doesn't think she's got anything to contribute. I am hooked. Tell me about what this county was like when you were growing up. There weren't that many people here. So she started telling me about her life. She remembers when the roads were paved. I'm talking, there were no paved roads when she was growing up. None. She remembers the first road that got paved. There were two families in Inverness, and they did not get along, kind of like the Hatfields and McCoys type thing. Well, the son from one family was supposed to marry the daughter from another family, and she ran off with somebody else. And boy, was that a scandal for months. And all the fallout, the political fallout from it. And she just had a ball recounting these stories. Amazing. This isn't stuff you're going to see on a website or in a textbook. This is real. So don't think that your patients don't have something to offer you. All you got to do is give them an opening and a question. Your patients will do the rest. If you want to be known as a great conversationalist, learn to ask a question and then shut up. It'll make you the best conversationalist in the room because people do want to talk about themselves. It's a topic they're most familiar with. You just have to give them an opening. Make sense? When you're feeding somebody, that is the best time to have those conversations because it'll keep you a little more engaged and that'll slow down your feeding. Otherwise, you end up doing this because you're just task oriented. Does that make sense? Does that make sense? All right. So we're not going to use a barrier on the table for this. We don't need a barrier because our food tray is the barrier. Okay. So no barrier on the table. We don't close the privacy curtain. You have to sit. You cannot stand over somebody and shovel food into their mouth without them feeling dependent and rushed. Have a seat, sit eye to eye, open expression, and show that you're interested. And then ask them some questions. They'll take it from there. Nod at the right places, make the right noises. Even if your brain is off doing something else, at least look interested. I generally am interested in what my patients have to say, though. It gives me an idea into their psyche, into what makes them tick. Okay. So we're going to ensure our patient is upright when we feed them. And if your patient starts to slump or slouch as you're feeding them, kind of keep your eye on this. Make sure that they stay upright. So probably about 20 years ago, my father-in-law was in the hospital, and he had had some pretty serious health problems. He had been in ICU. They finally transferred him up to the floor, getting ready to send him home. I went in one morning. It's probably about 8:30. I get there. He's in bed, and the bed is reclined probably about that much, right? It's not upright. It's like semi-reclined. He is sitting in bed, and he's got a food tray in front of him, and there are scrambled eggs all over him. His face, his lap, the bed, the floor, I mean, just like everywhere. And I went out and I asked the CNA, I said, what's going on? You know, why does he have egg all over him? And she's like, oh, I don't know. He's feeding himself. Ask him. That was the response. So this isn't exactly what I'm looking for here. And I said, okay, I can see that he has egg all over him, but he's not sitting up and he's very confused. She says, and? Well, he just came out of ICU into regular floor because he's supposed to be going home. He was not confused last night. He is confused today. And there's scrambled egg everywhere. Doesn't that tell you that maybe there's a change here that should be looked into? And she says, he's old. They're all confused. That was her response. He's old. They're all confused. Okay, if that were true, so there's two competing problems here. If that were true, if you think that all old people are confused, that means that you are responsible for their safety. Should you have brought a tray into him without the head of the bed being up? So that's a problem. If you think that he's aware enough to put himself up to feed him and he's got scrambled egg everywhere, is that a problem? So either way you go here, there's a problem that isn't being addressed. Yeah, she didn't like me. She actually went and told the nurse that I was combative because I'm trying to ensure that they don't kill my father-in-law. When family brings this stuff to your attention, don't get defensive. She probably missed it. I get it. She's got 14 patients to take care of. I understand. Had she says, oh my gosh, I didn't realize, let me let the nurse know. We'll get right on that. This situation would have been super resolved, no problem. But the fact that she got belligerent with me was why I walked straight into the DON's office. And I filed a complaint. Because if she's going to do this to my family member, she's doing it to others, and they may not have somebody to stand up for them.
Especially when you're out of state.
Yeah.
Mine was because my dad was in Kentucky. They think that, well, they're not going to come see him. We can do what we want.
Right.
I've caught it many times, dropping in.
Isn't that horrible?
It's sad. Very sad.
We've got to do better than that. We've got to do better. Okay. So if they start out sitting up and you notice somewhere along there they're not sitting up anymore, address it. Good. It's all about safety. Okay. We're going to offer a hand wipe. Now, there's two reasons for this. The state's going to give you one. I'm going to give you the other. The state says you have to offer a hand wipe for infection control purposes, because even though we're feeding the patient, if they have any mobility at all, they may bring their hand up and push food into their mouth. We want their hand to be clean for that. I absolutely agree. Good call. No problem. But there's another reason that you want to offer a hand wipe that the state doesn't really talk about, and that's ritual. Most people wash their hands before they eat. It's part of the eating ritual. And even though we can't get them to the sink by giving them a hand wipe, we're giving them clean hands for infection control purposes, but we're also trying to maintain that eating ritual as much as we can, which will help improve overall intake. Good? Does that make sense? Okay. We're going to offer a clothing protector. That clothing protector, the patient may say no. I'll give you a great example. My grandmother was probably the most prim and proper person on this planet. You offer her a clothing protector, she'll tell you straight to your face, I am not a child. I do not need that. No problem. Me, I need a clothing protector, and I'm not even a patient, right? I wear everything. If I'm eating it, I'm wearing it. Okay. So you offer me a clothing protector. I'm going, yep, please, thanks. Okay. So everybody's an individual. We don't force, but we do offer, especially if somebody else is feeding them. They can't control how much your attention you're going to pay or how much you're going to tremble. And they don't want their clothes ruined by chocolate pudding. So offer a clothing protector, honor their wishes. It's pretty simple. We're going to sit while we feed the patient. You need to be eye to eye. This is all about superiority, inferiority. It really is that simple. When you stand over somebody, it puts them in a dependent mindset, and that can affect how they eat. And let me go into this. People that are being fed do not eat well. They don't. Very few people being fed will eat 100%. Very few. Now, it's not because they don't have an appetite. It's because of this. It's because of that dynamic. Eating is the very first skill you get independent at. The very first one. You learn how to hold a bottle before you know what hungry is. You pick up diced peaches and Cheerios off a high chair tray before you're able to sit up fully. You feed yourself. That's a first skill you become independent at. So when you lose the ability to feed yourself, psychologically, it impacts you way more than any other skill. This is legitimately the hardest skill to be a patient for. It is easier for a patient to allow you to be in their private areas cleaning them than it is to feed them. I want you to think about that for a second. This is the most intimate skill you will do with a patient. That's a whole lot of pressure. A whole lot of pressure. And because of that, because patients aren't comfortable with this, they stop eating. They'll eat maybe half and they'll say, no, I'm done. So what you do after that is going to matter. If you go, thank God I got 1 million people to feed, I'm, running late, and you just get up and go, you've just reinforced the fact that they are an imposition. So you really need to use 2 forms of encouragement. I'm going to give you 3. You need to use 2. First thing I ask somebody who stops eating is, are you sure you don't want just one more bite? Come on, just one more for me, please. One more. Usually I can get somebody to take one more bite because I'm sweet. Turn up the charm. You can get people to do what you need them to do. You can get a whole lot further with patients by being nice than being mean. Now, that's not to say there are some patients that I find that if I get a little more stern with them, I can get them to work around to my way of thinking. But for the most part, sweet is the way to go when it comes to feeding. So are you sure you don't want just one more bite? Please, for me, just one. Come on. Usually I can get them to take a few more. The second thing I do, and we've all had these days, is I offer them something different. Can I get you something else from the kitchen? We've all gotten something, took a bite, and it's like, nope, not it. Not what I was looking for. Not what I want. So what if your patient's having that day? They took a few bites and it's like, nah, it's just not what I'm looking for. They can't go to the kitchen and make something else. They can't drive to Wendy's or Taco Bell or wherever and get what it is that, but we can offer, can I get you something different? And then I usually let them know that food is available if they get hungry later. Just let me know. We got some snacks in the back. Be happy to give you one. That way they don't think that it's all or nothing. Okay. If you do this consistently, if you use at least 2 of those, it lets your patient know that you're interested in them, not the task. And that eventually will get them to eat a little bit better for you. Okay. This is especially important if you're working with diabetics. This is critical if you're working with diabetics. Because when we have diabetics that are on insulin, we give insulin based on the food intake we anticipate they're going to take. So if the nurse is given insulin before a meal and they don't eat the meal, that insulin has nothing to use up. And that can actually bottom out their blood sugars, cause them to go way low. So when you're working with diabetic patients, we really need to get them to eat everything on their tray, everything. And that may take a little work on your part. Okay. Good. So this is one of my pet peeves about the way that our long-term care society is going. They hire feeding assistants. Used to be CNAs did this, feeding, and you still do in a lot of settings. But now they're hiring feeding assistants. It's all these people do is feed patients, and they're giving them a 2-hour training to feed somebody. I don't like that, because I think that as CNAs, we have a deeper connection with our patients. We're doing a lot of tasks with them. We're in and out of their room all day, every day. They know us. They're going to connect with us. It makes feeding them a whole lot easier, less intrusive, less scary. When you put a complete stranger in front of them who doesn't care, they're not going to eat. I don't like the idea of feeding assistants, but that's just my soapbox. All right. We're going to offer a drink before we feed them, and every 2 or 3 bites. This is why your person is being told to take 4 bites, because somewhere in there you should be offering a drink. If we get to drink 4 and you didn't offer a drink, you're not going to. So that's why they're only taking 4 bites, and then they're going to tell you they're done. Are you starting to see why their instructions are going to play into all of this stuff that I'm telling you? It's very specific. Now, everybody has different eating preferences and drinking preferences. My aunt, she had been a model when she was younger. And in order to keep her figure, she drank an entire cup of water before she ate anything. And she claimed it filled her up and kept her from eating too much. This is something she had done pretty much all of her adult life. So she would always get a big cup of water, drink it all down, and then she would eat. It worked great for her. It does not work at all for me. I've tried it. Does not work. I just get sloshy and hungry. So that, that's fine. Now, there are some people that are going to drink with a meal. That's me. I don't have a lot of saliva, so that's why I have to drink so much when I'm teaching. So when I eat, I take a couple of bites, and then I have to take a drink to help everything move around and swallow and digest and all of that. And then there's some people that don't drink before a meal. They don't drink with a meal. They drink after their meal. Think about what camp you fall into. Not everybody in here is the same. So that's why we offer a drink before. We offer a drink every 2 to 3 bites. And you can offer a drink at the end as well. But it's up to your patient what they are going to do. Make sense? Now let's talk about eating. If you think drinking is different, eating is way different with people. How many of you guys don't like your foods to touch on the plate? Okay. How many of you guys eat all of one thing before moving on to the next thing? Okay. How many of you guys take a little bit here, a little bit there? Yeah. How many of you like your corn and mashed potatoes mixed? How many of you find that revolting? Yep. So everybody has different eating preferences. Don't assume the way you eat is the way somebody else eats. I'm going to give you a story about this. Oh, I have nightmares over this one. I was a hospice nurse working in long-term care, so I went into a nursing home to see my patients. This particular patient, she had had a stroke, and she was nonverbal, right-sided paralysis, and she had cancer, and the cancer was why she was on hospice. So I go in to see her. She's in the dining room being fed by the CNAs. No problem. I sit down, and we're going to call her Mary. And I said, hey, Mary, how's it going? And she just kind of, she was nonverbal, but she was very expressive. And she rolled her eyes and turned her head. And I could tell that she was not pleased with whatever was going on here. Now, she couldn't tell me what it was. But I said, oh, that good, huh? What's for lunch? And I look at her plate, and her plate is just gray goo. I mean, that's the only way to describe it. Dark gray goo. I looked at the CNA. I'm like, what's for lunch today? She says, Salisbury steak, mashed potatoes, and beets. And I said, okay, well, what is that? She said, Salisbury steak, mashed potatoes, and beets. I said, you mixed it? She says, yeah, when it's pureed, they can't taste it. Oh, no, they can taste it. Puree does not mean bland. It doesn't mean no taste. It just means no chew. Would you eat Salisbury steak, mashed potatoes, and beets mixed? She says, no, that's disgusting. Exhibit A, go get her a new tray. She says, well, I don't think the cafeteria will give me one. Go get her a new tray. She's not eating that. I won't let her eat that. I'll go to Wendy's. I'm not going to let her eat that. That's disgusting. She clearly doesn't want it. Don't mix stuff together unless your patient wants that. Does that make sense? It was just disgusting. Don't do that. And puree does not mean bland, by the way. It's all the flavor, just none of the chew. Okay, good? Okay, we're going to feed slowly. Spoon should only be half full. Don't overload the spoon. When we were a testing center here in Spring Hill, the evaluator came out, and I love one evaluator I absolutely love. The other one I couldn't stand. But the one that I love, she comes out and she's just rubbing her head like she had a headache, and she's shaking her head. And I'm like, what's going on? She says, you're not going to believe this one. So somebody was had feeding and had pudding and clearly was very, very nervous. And she was overloading the spoon. I mean, heaping spoonfuls and shoving it in as fast as she could. Wasn't giving the student time to chew and swallow. So this person is having all of this stuff, I mean, coming at her, chocolate pudding dripping down her face onto her clothes. And the girl she's just going as fast as she can. As she puts the container down, she says, I'm done. Like it was a speed eating contest. And it happened so fast that the evaluator didn't have time to do a safety stop. She's like, it was done within like 5 seconds. Don't do that. What does that tell you about what kind of CNA that's going to be?
Unprofessional.
Unprofessional, not caring, but not aware of safety. Putting their needs over the patient's. Does that make sense? Oh, that one gave the evaluator a headache. I know, I saw it. She complained to me about it. Crazy. Wasn't one of my students, thank God. I would have had to have a talk there. So the spoon should only be half full, and we're only going to get 4 of them. So in reality, it's only going to be about 2 full spoonfuls of pudding or applesauce that this person is going to eat. Okay, good. All right. So we're going to have a conversation. Doesn't have to be real for the test. You can make something up. I don't care what you say, but have a conversation. Okay. All right. We're going to encourage them. We already talked about this. Use 2 forms of encouragement. Don't you want another bite? Can I get you something else? If you get hungry later, let me know. And we're going to leave the area around the mouth clean. This is, remember, we talked about this with mouth care. We talked about it with denture care. We're going to talk about it again with feeding. Look at the mouth, make sure it's clean. Okay. And then you're going to do your closing. So at the end of this skill, you will have to document. Our care plan tells us to document. We're going to document on a food and fluid intake sheet. So if you, in your book, go to page 169, you can see the food and fluid intake sheet. You'll see that there's 2 check boxes that say snack and meal. Which are we giving? Snack. Yeah, it's a single serve pudding. Our care plan tells us it's a snack. Okay. It's going to ask you to estimate the percentage that the patient ate. This is on a quarter percentage scale. It also asks you to estimate the amount of liquid they drank on a quarter percentage scale. Go ahead, Jake. Okay, yeah. So this is, we're going to go back one in a minute, but this is a quarter percentage scale. If they eat nothing, it's 0. If they eat all, it's 100. If they eat half, it's 50. Now, the other 2 are kind of closest estimates. There's nothing really scientific about this. It's an estimate. If they didn't refuse it, if they picked at it, but didn't eat half, that's going to be 25. If they ate most of it, but didn't quite finish, 75. Okay. So those 2 are where we kind of get into gray areas, 25 and 75. Does that make sense? And this is really a judgment call, to be honest with you. But I'm going to try to help clear it up in just a minute for you. But one of the things that I need you to understand here is that for the test, you're only giving 4 half spoonfuls. So it's not 0, but it's not going to be half. So for the test, what are you going to document? 25%. That's right. Now, liquid is going to be up to the they may refuse all liquid. They might drink the whole cup dry. I don't know what they're going to do for the test. But I know that the food part should be 25%. Good.
There's not a 25% on there. Do we write it on there?
There will be, because look at,
Really?
yeah, if you look at that form, you'll see there's 0.
Okay. I was taking 25% with the meal, or the 25% with the meal.
Oh, yeah.
I was reading.
Yep. 0, 25, 50, 75, and 100. You're going to find the one that's closest to what they ate. Good. All right. So go back, Jake. So the details are what we're being graded on here. Offer a hand wipe before feeding, offer a clothing protector, offer a drink before feeding and every 2 to 3 bites. We're going to let them lead, feed slow. Don't use childlike feeding techniques. No planes, trains, or automobiles. Okay. For the test, we're going to do this professionally, by the book. Now, I'm going to tell you there are patients that I have cared for that I absolutely have done airplane. Sure. To get them to lighten up, get them to laugh a little bit. Remember, the human connection is what's going to influence their intake. So yeah, absolutely. I have fed adults with airplane sounds. Sure. But you're not going to do it for the test. And you're not going to do it with everybody. If I had done that with my grandmother, she would have thrown the food tray across the room. So you got to know your audience. Okay. Good. Go ahead, Jake. Yeah. All right. So this is a estimation on feeding percentages. So remember I said, right, that this is a judgment. But in order to figure out how much they ate, we kind of have to know what they started with. So if you look at that tray at the top, it shows that we have a sandwich, some broccoli, and some Jell-O. I don't know who would serve broccoli with a sandwich, but we're going to go with it, okay? So sandwich, broccoli, and Jell-O. So if you look at the first one there, they took a bite out of the sandwich, a little bit of broccoli, and a few cubes of Jell-O. How much do you think we would estimate they ate? 25. It's not half. It's not half. But it's not a refusal either. Good? Let's go to the next one next to it. They ate about half of the sandwich, about half of the broccoli, and about half of the Jell-O. Well, not quite on the Jell-O, a little bit of the Jell-O. What would we give them credit for there? About half. Yeah. Yeah. So let's go down here to this one. They ate most of their sandwich. They ate most of the broccoli and about half of the Jell-O. What do you want to give them credit for? 75. Now the last one's tricky, right? They ate all the sandwich, almost all the Jell-O, and all the broccoli except for one stem. What do we want to give them credit for here?
100.
I'm going to say about 100. Yeah. So you could call this 75, but this really is closer to 75 than that one. That's closer to 100. Broccoli stalks don't really count. Right? Yeah. So this is, and I know it's not scientific. It's not a count. I get it. This can mess students up a little bit, especially if you're very analytically thinking, linear thinkers. The best thing to do is to go by the big three, right? Did they eat 0%? Did they eat close to half? Or did they eat all? Okay. And if it's not one of those three, kind of estimate the ones in the middle. Is it closer to? Is this closer to 75 or 100? Does that make sense? Okay. Good. All right. So we have a way of documenting fluids that is much more analytical, scientific, linear. So if that 25% scale messed you up, it's okay because this is going to set you straight. So food and fluid intake is based on that quarter scale. Intake and output is based on this. Sometimes your patients will be on an intake and output measurement. That means that we're measuring, hard and fast measuring everything that goes into the patient and everything that comes out of the patient. We're actually measuring it. And when your patient is on intake and output, we have to know how to measure it appropriately because we're working with actual numbers here. So in healthcare, we don't use ounces. I know in America we do, but not in healthcare. In healthcare, we use the metric system. So this is going to be measured in mLs. mLs and cc's, same thing. Two different names, same measurement. mLs and cc's. So what we need to understand is there's a conversion between ounces and mLs. If we know how many ounces somebody drank, we can then find out how many mLs that equals. And the conversion is 1 ounce is equal to 30 mLs. So if I have a 6-ounce cup of juice and they drink it all, I would multiply 6 by 30 and get 180. So this person took in 180 cc's of juice. If they had a 12-ounce cup of coffee, I would take that 12 ounces and multiply it by 30 to get 360 mLs. You will have a math problem on the test. It will either be conversion, ounces to cc's, or adding up all of the cc's to get your daily total. So if I have somebody that drank 6 ounces of juice, which was 180, and 12 ounces of coffee, which was 360, if you add 180 and 360 together, that gives you the amount of intake for that shift. So you will either have a conversion or you will have an addition problem. They don't let you take in scrap paper on the test, but they will give you a whiteboard that you can do your math on. Okay? Not allowed to take a calculator in. Good? Does that make sense? Now, when you go to work, wherever you go to work, they are going to have coffee cups that they use. They are going to have, their normal water glasses. And when you go through orientation, they're going to tell you, okay, our coffee cups are 8 ounces, our water cups are 6 ounces, or whatever the case may be. That allows you to know for this. If they drank 2 cups of water and their water glasses are 6 ounces each, they had 360 cc's. Good? Makes sense? Go ahead. All right, go back. Page 106 has, this is a worksheet for you to be able to go through. And this allows you to estimate how much intake for food. But it also down here has that conversion. Now, one thing I want to point out, if you look at that milk carton in the middle, it actually tells you on the milk carton how many mLs were in that milk carton. How many? 240, right? 8 ounces equals 240. But sometimes the mLs are way more specific than our general times 30 type thing. So if you look at your water bottle right there, you guys have all got water bottles. If you look at your water bottle, how many ounces are in your water bottle? 16.9. Next to it, it tells you how many mLs. 500. So the mLs are actually way more specific in this case. If you did the multiplication, it would come out different. So if you're using a pre-packaged food product, they will have mLs on the label. Go by that number. Okay. Does that make sense? Okay. So in this case, we have 6 ounces of juice. How many mLs is that? 6 times 30 is 180. So if you write 180 in there. Under the milk, the milk carton tells us 240, so write 240 in there. And 12 ounces of coffee, 12 times 30 is 360, yep. So write 360 in that one. Now, at the very bottom of the page, it asks you to add all that together. Good question, Alan. Add all that together. What do we get? 780, absolutely. So that is our total intake for the day. So Helen asks, can they give you a subtraction problem? No, they won't. Yeah, it'll either be addition or a conversion. There won't be any subtraction. I can't think of any problem that would require, I can't think of any that would require subtraction. Nope. Okay. Good. Do you guys understand intake and output? I have a whole lesson on it in your book as well. All right, page 132. This is another worksheet that you can do to help you understand medical medical abbreviations. In healthcare, we have some accepted abbreviations that just make it easier for us to communicate with other healthcare workers. The first column are the ones I really want you to pay attention to, particularly if they're highlighted in gray. If they're highlighted, you definitely want to pay attention to them. But if you look about 3/4 of the way down, you're going to see one that says NPO, and that's the one we're going to focus on right now, NPO. NPO means nothing by mouth, but if you try to make sense out of it in English, you're going to be all kinds of confused because there's no words that could make this mean nothing by mouth in English. That's because this is not English. It's abbreviated Latin. Latin is the language of medicine. It's actually the language of science, but medicine is science. So a lot of the things that you're going to see in healthcare are actually based in Latin. Okay, good, makes sense? All right, so there's a story here. I'm gonna real quick. I have to tell you this story. So when we had the scrub shop, a woman came in. We're going to call her Kathy to protect her. Kathy came in. She worked down at a teaching hospital down in Tampa, and she worked in the cardiac cath lab. And she went up to get a patient one day for first case of the day to have a heart cath done. She walks in the patient's room. It's like, I don't know, 4:45 in the morning. I mean, just like crazy early. Patient's sitting up in bed eating. She's like, why are you eating? You're supposed to be having a procedure. You're NPO. Patient says, I know, it's weird. But the nurse came in, brought me this tray and said I had to have it. So I'm eating it because she told me. Cardiac cath nurse goes outside to the nurse that was supposed to be taking care of the patient, says, why is the patient eating? And the nurse says, oh, I don't know. The student nurse is handling that one. Go ask her. So the cardiac cath lab went and found the student nurse. And this is the conversation as it was relayed to me. Okay. You'll play both parts. Cardiac cath nurse. Why is the patient eating? Student nurse. Because the patient's NPO. Cath lab. I know the patient's NPO. Why are they eating? Student nurse. Because they're NPO. What do you think I'm sorry. I had to go down and get the tray special. What do you think NPO means? Nanas, pineapples, and oranges, a fruit tray. To get them cleaned out for surgery. Nana, not even bananas, nanas. Nanas, pineapples, and oranges. This is what the student nurse, the mental gymnastics she had to come up with to try to figure out what NPO meant instead of just asking. If a medical abbreviation is used and you are not familiar with that medical abbreviation, your obligation is to get clarification, not guess. Now, what really aggravated me is that Uncle Google is hitching a ride in everybody's pocket at this point. So all they had to do was pull out their phone and type in, what is NPO? And I guarantee you, Uncle Google would not say nanas, pineapples, and oranges. Now, can you imagine this cath lab nurse having to go back to the cath lab and tell the doctor who's already scrubbed in, we don't have a patient? That doctor's losing money. You think they're happy with that?
No.
They have to scrap all of the sterile process, all of the drapes, all of the instruments. They've been opened. They cannot be used now. All of that, the whole room had to be stripped and cleaned for the next patient. And here's a patient that needed a cardiac cath done that is now having to wait hours or a day. So they're not getting the care they needed, all because of one student that decided to fake it till she made it. She didn't make it. NPO is abbreviated Latin, not English. But it's not the only abbreviated Latin. If you go up to the top of the page, you can see a lot more. PRN, abbreviated Latin, means as needed. STAT, abbreviated Latin, means immediately. QH, abbreviated Latin, means every hour. BID, abbreviated Latin. Let me tell you a little secret on those, BID and TID. B stands for bi. How many wheels are on a bicycle? Two. So BID means 2 times in a day. So TID, T stands for tri. How many wheels are on a tricycle?
3.
So what do you think TID means?
3.
3 times a day. Then you get to the bottom of that section, you see QHS, which is really confusing. This is how in Latin you say bedtime, hour of sleep, right? The hour you go to sleep. That's how they say bedtime. So QHS is every bedtime, every hour of sleep. Good? Make sense? All right, so page 169 has a documentation form for intake and output. So if we're estimating, we're going to use the food and fluid intake form. If we're using numbers, it's going to be on an intake and output sheet. You guys see the difference there? Okay. And then I've got a whole lesson on page 107 about intake and output, which basically goes over everything I just talked about. Questions? All right, so I know it's a whole lot of talking, like an hour's worth of talking to tell you how to feed somebody, and you already know how to do that. Feed them slow, give them time to chew and swallow, have a conversation, make sure you're sitting at eye level, don't rush them, offer a drink before and every 2 or 3 bites, make sure you give them a hand wipe before, offer a clothing protector, and then fill out the documentation form after. Easy. But I needed to make sure you knew all the other stuff because that's the stuff that might show up on the written test. Good? Let's go ahead and watch this video.
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. Would you like a snack?
Yes, please.
Okay, I'm going to go wash my hands, get my supplies, and I'll be right back. Can I ask you to sit up straight for me, please?
Okay.
Thank you. Okay, Mr. Jones, let me get you a hand wipe so that you can wipe your hands. Would you like to take that? Thank you very much. Let me dispose of this. Okay, can I offer you a clothing protector?
Yes, please.
I'll just place this on your chest. Okay, it looks like we have pudding. How does that sound?
Great.
Very good. Can I offer you a drink before we get started?
Please. Thank you.
You're welcome. Okay, are you ready?
Yes.
There you go. Do you have any plans for this afternoon?
No, I do not.
They're showing a movie on the big screen in the activity room. Would you like me to get more information on that for you?
Yes, please.
Okay. How does the pudding taste?
Delicious.
Very good. Ready for another?
Yes, please.
Okay. Can I offer you a drink? Would you like something to drink?
Yes, please.
All right. Ready for another bite?
Yes, please.
Ready for another bite?
I'm actually full.
Are you sure you wouldn't like just one more bite?
I'm okay, thank you.
Can I get you something else from the kitchen?
No, thank you.
Okay. Let me know if you get hungry later, and we'll get something to eat. We do have food available on the unit.
Thank you.
I'm going to take the napkin. There we go. I'll remove this clothing protector from you, and we're going to put this in dirty linen. I'm going to go take care of your tray. I'll be right back.
Okay, thank you.
Okay, I'm going to place the tray back on your table. Is there anything else I can get for you? A magazine, perhaps?
No, thank you.
Your call light is within reach. Please let me know if you should need anything. I'm going to go wash my hands and document.
Okay, thank you.
After washing my hands, I'm going to document the amount of food that this patient ate. Using my documentation form, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right. Ooh. Yes, I should have. Yes, I should have. You guys are good. I was just about to ask. Is there a step I missed? Yes. So the reason that the videos don't show that, and they're not going to show it on any of the documentation skills, the older videos, is if I'm wearing blue, it's an old video. If I'm wearing black, it's a new video. It's the easiest way to remember it. But the reason is that this step, washing your hands after documenting, was added after those videos were produced. Yeah. So the new video, if I'm wearing black, it's in there. I'm working on the new videos. All right. So any questions on that? Any questions on feeding?
Shouldn't you have worn gloves?
So that's a great question. And the answer is only if the care plan tells you to. The reason for that is that you aren't directly interacting with their saliva. Generally speaking, when you're feeding patients, they keep their body fluids to themselves. We're just on the other end of a spoon. The problem with gloves is that gloves have an odor. They give off an odor, and especially latex gloves. Latex is an appetite suppressant. So when you have that glove right here, to put the spoon in, it's right under their nose, and our appetite is driven predominantly by aromas. So having a glove that close to their nose can actually kill their appetite. So if the care plan wants you to wear gloves, try to wear vinyl or nitrile gloves because it has less of an appetite suppressant effect. That does not mean those of you trying to lose weight should walk around sniffing gloves. Okay? Please don't do that. All right, so we're moving on to page 152. This is Peri-Care. Peri-Care. This is a long skill. This is our second longest. Remember, our longest skill was partial bed bath. We had 19 minutes to do that one. This is the second longest skill. We have 17 minutes to do this. If you look down here, you can see all of the principles involved. Again, they're going to be spelled out here. Everything but shoe rules. Everything but shoe rules. We're going to use everything that we've learned in this skill. It's a big skill. Down here, you can see we're going to be doing this on a mannequin. That mannequin will be laying in bed. Documentation is not required. Go ahead. So at the top, page 153, we have our care plan. This one's short and sweet. It says the female patient has been incontinent of urine and needs perineal care. The pad under the resonant is wet, but the gown and bedding is dry. That's a miracle. Does not happen like that. But we're going to take the gift that the test gives us. Okay. And go back one real quick. And even though our care plan says that the pad is wet, it's not. It's a mannequin. She's not really wetting anything, right? So even though the care plan says the pad is wet, you're still working with everything dry. Down here are your supplies. There's a lot of supplies for this. We are going to use that leaves method again. And we're going to use clean rolls toward me, dirty rolls away when we're changing out those chucks. But in order to understand how we're going to do this skill, we have to talk a little bit about what incontinence is. So go ahead. This is a 5th grade version of the urinary system, guys. 5th grade. It's a normal functioning urinary system. You got 2 kidneys. They filter blood 24 hours a day. 24 hours. They never stop. 24 hours a day. Drip, drip, drip. It filters blood, produces urine. That urine drips down tubes called ureters and collects in the bladder. This little valve down here is what holds the urine in the bladder. That valve is closed. Since the valve is closed, all of these drips accumulate in the bladder until it gets full. Your bladder rings a bell in your brain, says, hey, find us a bathroom. You go to the bathroom, valve opens, all the urine comes out, valve closes, you go on about your business for another couple hours. We all know how this works, right? Okay, go ahead. When we're incontinent, what is broken is the valve. Everything else works. Kidneys still filter blood, produce urine 24 hours a day. That does not change. Those urine drops go down the tubes. That does not change. They go into the bladder. That does not change. What has happened here is this valve doesn't keep those drips in the bladder, so they come out. Remember that urine is produced 24 hours a day. So drip, 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 drip. All of those drips, if they're not staying in the bladder, are going to come out. When you have an incontinent patient, they are going to be wet all the time. If you have a patient who is dry, 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 their valve works. They're not incontinent. They're not incontinent. What you have is incompetent staff members who don't want to take the time to get that patient up into the bathroom. That's what you have. Now, this is such a problem out there. This is horrible. This, to me, I think is the most criminal thing. There is such a problem out there. CNAs don't want to take patients to the bathroom because it takes a lot of time and a lot of effort. You got to get them up. You got to get their shoes on. You got to walk them all the way to the bathroom, and it takes forever because they're super slow. You got to get them to the bathroom. You got to sit them down on the toilet, and then you got to wait. Then you got to get them up, and you got to wipe them, and you got to pull their pants up, and then you got to walk them all the way back to the bed, and they're so slow. And then you got to get them to the bed, and you got to get the shoes off, and then you got to swing them around and get them settled back in the bed. That's a lot of work, and I understand that that's a lot of time. So for a lot of CNAs, they just tell the patient, just go, I'll clean you up. It's a whole lot quicker. Is that something we should be doing?
No.
That's a dignity issue. You do not tell somebody who is continent to violate their own dignity for your convenience. That is horrible. Criminals do not even get treated like that. This is such a problem out there that the agency that oversees healthcare settings finds facilities. If your patient came in continent and while they're here became incontinent, we're fining you $10,000 per occurrence. Because we know it's not a patient problem. It's a staff problem. Do you guys see how that's a problem? Right? So if your patient is dry, 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 really, really wet, everything here is working. Somebody's not getting them to the bathroom. Good. Now, I'm plugged into a ton of groups on Facebook. This came up again this week. This comes up almost every month. Somebody complaining. The nurse says, I'm not doing my rounds, but I went in and checked on the patient and they were dry. Yeah. If they were dry, they're not incontinent. So there's a lot of problems with the system as it's in place. Okay. If our patient is truly incontinent, they're going to be wet 24 hours a day. And because they're laying down, some of that urine is just going to kind of lay in the bottom of the bladder. So when we turn them on their side, what's going to happen? Yeah, it comes out. Absolutely. It's important that you know this. And this is why I didn't used to teach that little section of it, but this is why. Here in Florida, we had a male caregiver at an assisted living residence probably 6-7 years ago that beat a woman to death. Beat a woman to death in her own bed because he turned her over and she urinated, and he took that as a sign of disrespect. He had cleaned her, Peri-Care, turned her on her side, and because of gravity, urine came out. He thought that she was being disrespectful and killed her. You should not be working in healthcare. Right? That's a problem. So we have to talk about these things, because if I don't talk about these things in class and you guys go out and do something like that, I will feel for the rest of my life some amount of guilt for not covering it. Right? We don't kill our patients. We don't beat them to death. And we understand what incontinence actually is.
So is it possible for someone to be incontinent throughout the night, but during the day they're able to make it to the bathroom?
Sure, that is a possibility, and it's nocturnal incontinence. And what happens is, so as we age, all of our muscles get a little weaker, right? So our biceps are weaker, our legs are weaker, all of our muscles are weaker. Well, this is a muscle. So this muscle isn't going to be as strong as it used to be. That means that when we're up and about, we probably have to use some mental energy to prop this up, hold it closed. Well, when we go to bed and we go to sleep, that valve may open a little bit, and that can allow for the urine to escape.
Because I work nights, and during like my night shift, I have a lot of people that are in briefs because they may or may not have nighttime incontinence. But then during the day, when we get them dressed, we can no brief, just underwear. And I'm just like, if they can go to the bathroom, like I get it, like you're tired, you're sleepy, but like their bathrooms are right there, like they're
Right.
not far from their bed, like they can go
Yeah,
straight to the
Best case would be to get them up into the bathroom. Best case. But sometimes that does happen. You know, you hold that valve closed when you're awake and alert, but when you're sleeping, it can certainly open. We're going to talk about being in bed with briefs in just a minute, though. Go ahead, Jake. All right. So babies and adults, not the same. You can put a diaper on a baby, put them to bed, wake them up 10 hours later, and they still have skin on their tushes because baby urine is very mild, very neutral. Urine acidity is based on what we eat and drink. Babies aren't eating or drinking anything acidic. They're on formula or breast milk, which is very, very neutral. They're not eating, tomatoes and, soda and things with acid, coffee. I mean, all of these things have acid. Almost everything that we eat and drink, if it tastes good, it's got acid in it. Well, as adults, all of that acid is going to be excreted through our urine. So when we have a baby and we put a diaper on them, their skin isn't going to get a lot of skin issues because their urine is mild. We have an adult and we put an adult brief on them. That urine is acid. So we can't leave that brief on for a long period. In fact, we're going to have to change it every 2 hours around the clock to help prevent skin issues. Go ahead. So let's talk about these briefs then. That brief, while the patient is in bed, is holding in that urine. It's warm, it's dark, it's moist. Remember, those are bad things, right? Warm, dark, moist. But it's also acid that's being held right up against the skin. When a patient is out of bed and going to activities and things like that, adult briefs are a good idea because of dignity. Nobody wants to wet themselves and it be visible. So adult briefs are usually indicated when somebody is out of bed. We're still going to clean them and change them every 2 hours around the clock. But when they're in bed, there's a better way. Go ahead. So when they're in bed, a lot of times our care plan will ask us to leave the patient open to air. This allows light and air to circulate. We get fewer skin issues, fewer infections. It also doesn't hold the acid right up next to the skin, which again can cause skin issues. So some of your patients will actually be open to air, which means no adult brief, just being on a pad. That allows the urine to kind of pull away from the body on the pad. We're going to change the pad and clean the patient every 2 hours. Whether they have an adult brief or not, it's still every 2 hours. That doesn't change. Not everybody will be comfortable being open to air. Some people are more comfortable with an undergarment on. They'll be in adult briefs, but understand they have a much higher risk of skin issues and infections. Good? Absolutely. Absolutely. Air and light circulating, especially if they have incontinence, for sure. For sure. But not everybody's comfortable with that. How would we know who is who? Easy answer. Easy answer. Care plan. It's not up to us to ask that question. The nurse is going to cover that. Good? Good. So this patient is open air. They're laying on a pad. Now let's think about that pad for just a second though. Do you guys remember what normal body temperature is? 98.6, right? That's our normal body temperature. It's actually a range, but let's just cut to 90. Let's make it 98. I like easy numbers. Let's make it 98, okay? Body temperature around 98. Room temperature around 75. Big difference. Now, urine is actually a little hotter than body temperature. Urine's about 100 or 101 degrees because urine is made right up here in our furnace. Remember, we burn calories, right? So urine is made up here in our furnace area, which means that urine that's coming out is a little bit warmer than body temperature, about 100 degrees. So you get that 100-degree urine on this pad meeting room temperature. Room temperature always wins. That means that urine's going to cool down really quick. That urine is going to feel 75 degrees. Anybody ever go to the springs to swim? Anybody know what the temperature is of the water in the springs? 72. Yeah, 72. So how would you describe that water? If you jumped in that water, how do you describe it? Cold. Oh my gosh, it's cold. Well, this is just barely warmer than that. So this pad is going to feel cold, wet, and slimy to your patient. So open to air on a pad. We're going to change them every 2 hours, but that pad is not comfortable. What do you think the first thing your patient wants done is? Yeah, change the pad. But now we got a wet butt on a clean pad. That's no good. So once we get them cleaned up, we're going to change the pad again. So at the end of the cleaning, we have a clean butt on a clean pad ready to go for another 2 hours. Good? Good? Okay. All right. Yeah, we already did that. Okay. So we're just going to follow our washing rules here. Basins are no soap zones. We're going to use a paper towel to turn the water on. We're going to check it. They're going to check it. Remember, it should feel warm. We're going to use the leaves method for wet body openings. Well, we have one here. We're going to use the leaves method. Whatever we wash, we rinse. Whatever we rinse, we dry. Don't get our surface wet. Lotion does not apply to this. Go ahead. We're going to go through them. Sorry. Okay. Basins are no soap zones. Use paper towel to turn the faucet on. Warm water only. Allow them to check it. Change it if it gets cold or soapy. Use the leaves method. Wash, rinse, dry. We're going to use one leaf on each stroke. Change the water if it gets cold or soapy. And don't get the surface wet. We're not using lotion, so that's fine. Okay. All right, so our care plan, one more time. The female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. So let's look at what we're going to do for this care plan. First thing we're going to do is change that Chucks. Go ahead. Oh, keep going. Keep going. We know all this. We know all this. Okay, up, back. Okay, so the first thing we're going to do is change that Chucks. Clean rolls toward me, dirty rolls away. Remember that? That means that the waterproof side of each one is what's going to be touching. That prevents that transfer. So we're going to clean rolls toward me, dirty rolls away. Tuck it under their hip. Okay. When we get our patient ready, we're going to have to expose them. Think about where we're washing, right? We got to be able to see what we're doing. We want to expose them, but we want to do the minimum amount of exposure possible. So I'm going to take this blanket that's over the patient, right? I put the privacy blanket on, pull the sheet down. I'm going to take that blanket and I'm going to roll the gown up inside the blanket, just above their pubic area, not quite their waist. I only want to expose the area I'm working on and nothing else. And then, go ahead. And then we're going to lay the towel over their legs. So do you see how this just isolates the area that we're working on? So it makes the patient feel a little more covered, a little less exposed. This is way different than that. You guys are all uncomfortable with this. I'm uncomfortable with this. This is why we isolate the area that we're working on. Whoops. Good? Good? Okay. All right. We're going to wring out our washcloth really well. No drippy wet washcloths. And we're going to apply soap to all 5 leaves. I'm going to take the washcloth. I'm going to hold it in my hand with the corners pointing up like this. Tuck my 2 side corners in, just like this. I'm going to use my other hand to, at the top of her peri area, I'm too short for this. I'm going to put my heel at the top of the peri area and just kind of hold her open to get down the middle. I'm going to go straight down the middle, pull away, and fold that over. The second stroke will be down one side. So I'm going to go down the outside, top to bottom, fold that over. Down the other outside, top to bottom, fold that over. Now this area between the leg and the groin, this crease, I'm going to go down top to bottom, fold that over, and then down top to bottom. Good? Questions? Now notice what I did not do. The number one mistake that's made on this particular skill is people go down and then back up.
No, you can do that.
We don't do that because this is where all of our bacteria is hanging out. So this is a one-way trip, top to bottom, move away, fold over. Good? Questions? Whatever we wash, we?
Dry.
Not yet.
We
Rinse. Yes. Go ahead, Jake. Go ahead. We rinse. Yes. Whatever we rinse, we
dry.
dry. Go ahead, Jake. Dry. Again, we're drying top to bottom. Never back up. All right. So now we've got the front all done. We washed it, we rinsed it, we dried it, we're good. We're going to cover the patient back up because they don't want to be uncovered. Go ahead, Jake. So we're going to cover that patient back up, scoot them toward us, and roll them on their side. Go ahead, Jake. Scoot them toward us. Go ahead. And roll them on their side. And now we're going to clean their backside. Now with the backside, we're going to use that leaves method. So I'm getting a clean washcloth. I'm going to wring it out real well. So 4 corners. So 5 for the front, 4 for the back. I'm going to take this washcloth, go right here at the anal opening and straight up the crease. We're going to fold that over. Second leaf, one cheek, fold that over. Third leaf, the other cheek, fold that over. And the fourth leaf, straight up that crease one more time. This is a riverbed, guys. When your patient is laying on their back and they pee, that pee is going to go right up that crease. So we're going to clean it. We'll set this aside on our barrier. Whatever we wash, we
Rinse.
rinse. Go ahead, Jake. One more. And whatever we rinse, we
Dry.
dry. Go ahead. Yep. So we're washing and rinsing the exact same way. You only have to learn it once, and you're just going to repeat it without soap. When we dry up the same way we washed. Now that we've got a clean butt, go ahead. We're going to change that chucks one more time. Now we've got a clean butt on a clean pad. We're ready to clean up. Go ahead. So we'll return the patient to the center of the bed. I need gloves on. I got to touch all of these towels and washcloths that were all just up in my patient's business. I need gloves on for that. So I'm going to put all of my dirty items away. I'm going to clean my basin and put it back in storage with a paper towel. I'm going to get rid of my barrier. I'm going to clean all of this up. Go ahead. Once I've done, keep going. Once I've done all of those things using a paper towel, go ahead, then I can remove my gloves. Then, go ahead, I can take the blanket off. Now, I know I've touched the top of this blanket with my gloves. I know that. I know the top of the blanket might have some stuff on it. So when I take this blanket off, I do it from the underside of the blanket, the part I didn't touch with those dirty gloves. And then we're going to go put that in dirty linen. Go ahead. Then we'll do our closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? You're covered. Bed's in the low position. Environment is clean. I'm going to open the curtain. Here's your call light. I'm going to go wash my hands. No documentation required on this one, so that stops our skill. Easy. Easy. Good? Good? All right. Let's go ahead and watch this video. Go ahead, Jake. And then don't go anywhere because I still owe you a range of motion. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to do Peri-Care. Is that okay? Okay, let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'm going to start out with a barrier. This gives me a clean place to place my clean supplies. So I'll place the barrier on the overbed table. And now I'll start gathering my supplies. I'm going to need 2 chucks, 4 washcloths, a privacy blanket, a towel. I'll place these items on the overbed table. I'll need a basin and soap. And I'm going to need a set of gloves. Okay, Ms. Jones, let me go fill the basin. I'll use a paper towel to turn the water on. I'll make sure it's warm. Not hot, not cold, just warm. Ms. Jones, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place my washcloths in the water. Okay, Ms. Jones, I'm going to place this privacy blanket over you. This is going to help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket out, being careful not to shake it or snap it. And then I'm going to pull your sheet down to about your knees. Now I'll get my chucks ready for use. I'm going to unfold the chucks, hold it up lengthwise, and roll it toward me. And I'll repeat that with the second one. Clean rolls toward me, dirty rolls away.
Now I'll get my gloves on. Okay, Miss Jones, in just a moment, I'm going to ask you to scoot toward me, and we're going to roll you onto your left side so I can change the chucks that's under you. I'll place one of the chucks on the bed. Miss Jones, can you scoot toward me, please? Thank you. And roll up on your left side. 1, 2, 3. I'm going to roll the dirty chucks toward the patient. Tuck it under her hip. Unroll the clean one and tuck it under the soiled. Miss Jones, can you roll back onto your back, please? Thank you. And scoot to the middle of the bed. Okay, I'll come around to the other side of the bed now. Miss Jones, can you scoot toward me, please? And roll up on your right side. 1, 2, 3. We'll remove the soiled chucks from the bed and unroll the clean one. This is going to be thrown away. Okay, Miss Jones, we're going to start cleaning now. I'm going to roll your blanket up to about your waist. This is going to expose you. Please let me know if you're uncomfortable in any way. So I'll roll the blanket up, and on the way I'm going to try to get that gown rolled inside the blanket so that exposes only the peri area. I'll cover her upper legs with a towel, and then get my first washcloth. I'm going to wring this out and soak 5 corners. 1, 2, 3, 4, 5. Okay, Miss Jones, I'm going to clean now. I'll use the heel of my hand at the top of her peri area and my index and middle finger to spread her slightly open so I can clean down the inside middle, top to bottom, and then we'll fold that leaf over. We're going to clean the outside labia, top to bottom, down one side, and fold that over. The third leaf will clean the other side of the labia, top to bottom, fold that leaf over. The fourth leaf is going to clean this area between the leg and the groin, this skin fold, top to bottom. We're going to fold that over, and we'll repeat it on this side, top to bottom. Now we'll place the washcloth back on the barrier. The second washcloth we're going to wring out, and we're going to rinse all of those areas the same way we washed. So we're going to hold her slightly open to clean down the middle, top to bottom. Fold that over. We're going to rinse down one side of the labia, top to bottom. Fold that over. Rinse the other side of the labia, top to bottom. Fold that over. We're going to rinse the skin fold down one side, top to bottom. Fold that over. And the other skin fold, top to bottom. We'll set that aside. Now we're going to dry all of those areas using short, soft strokes or a gentle pat. I'm going to unroll the blanket, which will place her gown back over her legs. Okay, Mrs. Jones, I'm going to scoot you toward me now, and we're going to roll you onto your left side so I can clean your back side. Go ahead and scoot toward me, and we're going to roll you over onto your left side. 1, 2, 3. The evaluator will hold the mannequin in place for you to complete your cleaning of the patient's backside. Okay, I'm going to take the fourth washcloth, wring it out really well, and we're going to soak 4 corners. 1, 2, 3, 4. I'm going to start at the anal opening and go up the center crease, right up the middle, and we'll fold that leaf over. The second leaf will clean one buttocks. We're going to fold that over. The third leaf will clean the other side of the buttocks. We'll fold that leaf over. And the fourth leaf will clean from the anal opening up the center crease one last time. We're going to set that aside. Whatever we wash, we rinse. So I'll wring that out. And I'm going to rinse the same way we washed. So from the anal opening up the center crease, fold that over. One buttocks, fold that over. The other side of the buttocks, fold that over. and once more up the center crease. And then we'll dry all of those areas. Okay, Ms. Jones, I'm going to change that pad out from under you so you're on a nice clean pad. We'll roll the soiled chucks toward the patient and tuck it under her hip. Unroll the clean chucks and tuck it under the soiled. Ms. Jones, come on back, please. And scoot to the middle. Thank you. Okay, Ms. Jones, go ahead and scoot toward me. And roll up on your right side. 1, 2, 3. Thank you. We'll remove the soiled chucks from the bed and unroll the clean. Okay. Go ahead and scoot back to the middle, please. This is going to be thrown away. Okay, Ms. Jones, I need to put all of my soiled items away and clean my basin. I'll be back in just a moment to get you situated. These items will go in dirty linen. And the basin is going to be cleaned the same way we clean everything else. We'll dump the water into the sink, rinse the basin, pick it up with a paper towel and dry the inside. We'll discard that paper towel. We'll dry the outside and discard that paper towel. And then we'll get the soap. I'll use the paper towel to open the drawer and store the basin back inside. These paper towels will now be thrown away. The barrier is going to be disposed of. And now I can remove my gloves. Okay, Ms. Jones, I'm now going to gather the privacy blanket up and pull your sheet back up. So I'll collect the privacy blanket by lifting from the bottom or underside of the blanket. I'm going to pull the sheet up and ball the blanket up into a ball. That way no trailing edges will contaminate other surfaces. Okay, Ms. Jones, let me go put this in dirty linen. Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to go open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then let the evaluator know my skill is done.
All right. Questions? Questions? No questions. All right, so I don't have any on-screen graphics for what we're going to be going over right now, but I also don't, I do have a book, okay. But in your book on page 78, we skipped this skill, unfortunately, because we kind of ran out of time. So you already know how to do this skill. You know to follow the care plan. You know to do your opening. You know flexion extension is up, down. And we know to, exercise whatever the care plan tells us to for as many repetitions as the care plan tells us to. You know how to do this. I'm just going to show you the particulars of it. But if you read the care plan at the top of page 79, it'll tell us to provide the following range of motion exercise to the resident's right elbow and right wrist. Can I do the left? No. Flexion extension. Remember, flexion extension is up, down. So up, down of the elbow. This is up, down of the elbow. Elbow only goes in one direction, guys. If you make an elbow go other than this, you broke it. I mean, it's pretty that simple. It's a hinge joint, only goes up and down. How many repetitions should I do? 3, because the care plan told me to. Wrist, up, down. How many of you guys can show me what up, down of the wrist looks like? Yeah, you don't need me for this. All you got to do is read the care plan and do what it says, right? So this is flexion extension of the wrist. Should an elbow be supported? Yes. So your patient's going to be laying in bed. You're going to do your opening. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? I need to do some exercises on your right elbow and wrist. Is that okay? Patient's going to say yes. Now, this is done on a live person, one of you guys. I'm just going to do it on her because we've got her here and it just makes it a little bit easier. Okay. So is that okay? She says yes. I'm going to close my curtain. If it's my first skill, I have to go to the sink and physically wash my hands, soap and water. This is not my first skill today. So I'm going to simulate. My hands are clean. I'm washing my hands. Something like simulate just means say. So I'm going to come over here to her right side. Remember, it's always her right. All right, Miss Jones, I'm going to do all the work. All you have to let me know, all you have to do is let me know if there's any pain or discomfort as we do this. First thing I'm going to do is bend your arm up to your shoulder and back down like you're making a muscle. So to do this, we want to turn the palm up to give that good range of motion. We're going to bring the arm as far up to the shoulder as we can. Should we force it?
No.
No, we're going to go until we meet resistance. In this case, this is as far as we can make it. So we're going to come back down to start, go up again, down to start, and up again, down to start. Remember, your arm might bend all the way. It's whatever the patient can tolerate. Now we're going to move on to the wrist. So I'm going to keep that elbow on the bed. And we're going to bend the wrist forward and back. You can have them make a little fist if you want. Forward and back. And one more forward and back. And I should be monitoring this patient for pain throughout this entire thing. All right, Miss Jones, is there anything else I can get for you while I'm here? No? Are you comfortable? Good. Okay. Just straighten the sheet here. I'm going to give you your call light. Here's your call light. If you need anything at all, just let us know. Environment is clean. She's covered. Bed's in the low position. So I'm going to go ahead and open the curtain. Wash my hands. My skill is done. I would want that skill. I would want that skill. All right, you have 35 minutes of practice time. Jake, can you advance us, please? All right, so your homework tonight is, it says 2 and 3, it's not right. Your homework tonight is 8 and 9. 8 and 9 are your homework chapters for tonight. 8 is on nutrition. You may want to make some flashcards on the different diets. 9 is on rehabilitation. And then you only have 1 chapter to go. Look how close you guys are. On Monday, we have our last 3 skills. That's it. And then Wednesday is graduation. We're going to go over job search, employability tips, continuing education, renewal requirements and processes. I'm going to tell you how to form. We have a formula that we use to help you form your answer to that question you always get in an interview. Tell me a little bit about yourself. You know, the one that you blank on. Right? There's a formula you can follow to craft an answer to that is and presents you very well and truly explains to them why they should hire you over everybody else. So I'm going to help you with that. That's something that we'll do in class together on Wednesday. So you definitely want to be here for that. On Wednesday, you'll also bring your yellow book back to me, and we'll take a class photo that will go up on social media. Okay. All right. So the rest of the class is yours to practice. Those of you who are tuning in virtually, thank you guys so much for tuning in. We truly appreciate having you along for the ride. And we will see you guys on Monday. Have a fantastic weekend. And until next time, happy caregiving. Bye.